from the latest Globocan data. In India, the incidence of colorectal cancer is 65,358 cases annually, which comprises 5% of the entire cancer burden. Males 6.3% and females 3.7%. But what is very, very encouraging, and this is a statistic I was very happy to find out, was that from a cohort study from more than 22 countries, it was found that the 5-year survival of previously untreated colorectal cancers has now moved up to 60%. So now we have a really good benchmark to aim for. Clearly, this vast improvement in the outcomes has come by a very solid and a very clear movement and a paradigm from surgery only to surgery combined with all the other modalities. So today we have chemotherapy, we have radiotherapy, we have targeted therapy, we have immunotherapy, and all of those elements will be represented in today's program. So let me start by introducing the very first speaker, Dr. Naseem Sheikh. She is a consultant in radiation oncology at the Sir H.N. Reliance Foundation Hospital. And she's going to talk to us on enhancing radiotherapy outcomes with precision radiotherapy. Over to you, Naseem.
Thank you, sir, for the nice introduction. So I would be talking about, good evening, everyone. So I would be talking about enhancing outcomes with precision radiation therapy. So to begin with, as sir rightly mentioned, the rectum, along with the colon cancer, is the third most common cancer in the US. And in India, it is not that common, but instead is increasing. And according to the Globocan 2020 data, the male, it has reported 6.3% in the male, and in the female, it is about 3.7%. It is most frequently seen in people who consume high-fat diet with low fiber intake. So surgery was the mainstay of treatment. Because of the increased number of the local regional recurrences, when the stage goes up, which is about to around 20 to 50%, the radiation therapy was tried. So the radiation plays an important role in cases where the narrow confines of the pelvic limits the adequacy of resected margin, and when the tumor is in close proximity to the anal canal, which hampers the quality of life of the patient. Yes, that radiation therapy has been accepted as an established modality of adjuvant treatment, but there are some issues that need to be settled. So the sequencing of the treatment, whether preoperative radiation should be given compared to postoperative, is chemotherapy necessary along with radiation therapy? What should be the ideal time gap interval between the radiation and the surgery, and the total dose and the fraction size? So to begin with, what is the sequence? The Upasla trial was the only randomized trial available who has compared 471 patients to preoperative dose of 25 gray versus 60 gray. In this trial, the local failure reported in the preoperative arm was only 13% compared to 22%, and the 5-hour survival was better in the preoperative gum. But there was a higher toxicity, acute toxicity in the postoperative group, and the late toxicity was reported in the preoperative group. This trial was reported in 1990 in the Annals of Surgery. So the role of radiation has evolved over the last 3 decades, with its prevalent role in the adjuvant setting. But at the similar time, in the Europe, short course radiation therapy was evaluated, wherein before to the surgery, radiation 25 gray 5 fraction was used. So in this trial, which is a randomized trial with a 13-year follow-up, approximately 1,500 patients, they were randomized to surgery versus preoperative RT along with surgery. So in this case, the local recurrence rate reported in the combined mortality arm was 9% versus 26%, which was statistically significant. Also, the cancer-specific survival and the overall survival was also significant. This is the only trial, published trial, wherein the overall survival benefit has been seen in patients with short-course radiation therapy undergoing surgery. The other trials wherein the short-course radiotherapy was randomized was the SOCOM trial 1 and the 2, where the significant reduction in local recurrence was reported. All stages benefited. There was a prolonged time to local recurrence and distant metastasis, though there was no difference in the overall survival. But post-op mortality was also higher in group where radiation was used. In the Stockholm 2 trial, there was also a significant reduction in local control with significant reduction in the distant metastasis, significantly improved overall survival, but in this case, the post-operative mortality was much lower. So in the pre-TME era, the role of radiation was established, but the question arises in the TME era. TME itself reduced the local recurrences to about 5 to 10%. So question was arise whether the radiation, is there any benefit of adding radiation in the TME era? So to answer this question, the Dutch trial, the Dutch TME trial was the first one to answer this question. So approximately 1,900 patients were randomized to standard TME surgery versus preoperative RT, which is 25 grain 5 fraction, followed by surgery within 7 days. The local failure rate was significantly lower in the preoperative RT arm. Also, the 11-year follow-up data suggests the same, which is 5% versus 11%. There was no difference in the overall survival. The cause-specific survival was better in the RT arm when R0 resection was possible, which is statistically significant. The overall survival was also better in RT group, wherein the R0 resection was possible in the stage 3 tumors. Overall recurrence rate were also significantly better in the radiation arm. So with this trial, it was confirmed that the preoperative RT was preferred over the postoperative RT, wherein because of the better survival and the less toxicity. So with the new, the role of chemotherapy was evaluated, whether adding chemotherapy to the new adjoint chemotherapy group benefited so. So the two studies reported that the French study and the EORT study evaluated the use of chemotherapy along with long-course radiation therapy, wherein in both the studies, there was a reduction in the local recurrence with the addition of chemotherapy. But in French study, the pathological complete response was more in the preoperative RTA group where chemotherapy was used, whereas there was a tumor downstaging in the URTC arm along with the CTRT group. The Cochrane review meta-analysis for the preoperative versus postoperative RT reported that there is a high grade of acute toxicity in the combined modality arm. Pathological higher rates of pathological complete responses. There were lower recurrences, but there was no 5-year difference in the disease-free survival or the overall survival. So now the addition of 5FU-based chemotherapy became the standard of care, which improved the local control. So now, is preoperative radiotherapy better than postoperative RT? To answer this question, the German rectal cancer study group randomized patients, 823 patients in the two arms, surgery followed by long-course CTRT group, and then preoperative CTRT, which was a long-course RT, along with 5FU, which was a continuous infusion, followed by TME group. So the patients included were T3 and T4 node positive disease. So here it was found that there was significant improvement in the preoperative RT with a local failure of around 8% in the preoperative combined mortality arm versus 13% in the postoperative arm. There was no overall survival difference, but the preoperative RT had significantly reduced toxicity, which is 27% compared to 40%, and late toxicity were comparable. So with this German trial, the standard of care was preoperative CTRT followed by surgery. Now to evaluate whether short course RT is better or long course RT, various trials will begin. So to begin with, there were two established treatment schedules in the rectum which is followed. Neoadjuvant CTRT, which is a 5FU-based CTRT followed by surgery within 6 to 8 weeks. And another arm is the short course RT, wherein 25 grain delivered in 5 daily fraction without concurrent chemo, surgery performed within 1 week, followed by adjoint chemotherapy. So what is the basic difference between the short course RT and the long course RT? The total difference varies. In the short, it's 25, in the long course, at around 45 to 50 grain. The fraction size is higher in short course. The duration is shorter in the short course and is approximately 5 weeks in the long course. The BED is approximately 66.7 gray, and here in long course, it's 72.8. So the interval, the time to surgery is 1 week in short course, and whether it is 6 to 10 weeks in the long RT. Downstaging is not possible until and unless the surgery is delayed in the short course. Yes, there is around 50% downstaging with the long course RT. So with short course RT, no chemo is given, and with long course, chemotherapy has to be given along with the long course RT. So toxicity is obscure if Imrt surgery is performed, but it is grade 3 around 10 to 20% in long course. Late toxicity are comparable. So to compare is long course chemo RT is better than short course. Is to be done to find out whether is there any local control or survival benefit, what are the side effects, and is printer preservation possible. So the POLISH trial was the first trial which conducted it in 1999 to 2000 with randomizing 316 patients. The primary endpoint was printer preservation when the two arms were compared. So in this group, resectable T3, T4 patients were enrolled with low rectal cancer to 25 gray followed by TME within 1 week versus long course CTRT followed by surgery after 4 to 6 weeks. So there was no significant difference in the center preservation. However, there was more downstaging in the primary tumor and long course. There was no significant difference in the overall survival, disease-free survival, and local survival. Toxicity was more in the long term. The another trial was the TRG group trial. Here, the primary endpoint was the local recurrence. To compare the local recurrence between the two arms. Here, they enrolled around T3N0 patient of rectal cancer to 25 grade 5 fractions followed by TME in 1 week, followed by 50 grade 28 fractions after 4 to 6 surgery to adjuvant chemotherapy. In this case, the overall survival was similar, distance recurrence was similar, and the late effects was seen in both the cases and were comparable. So again, there was no any significant difference, respective only that the POLISH trial, the resection margin, the downstaging was better in the post-operative group. Pathological complete response was seen more in the post-operative group. And also there was no difference in the overall survival, local regional recurrence, and the disease-free survival and oral survival. Toxicity also were comparable, but in the POLISH trial, the toxicity was less in the preoperative arm. So as you can see, there is no difference in the local control between the two trials, the POLISH trial and the TRG-OT trial. The overall survival is also same between the short course RT and the long course RT. So what are the ISMA guidelines recommendation? Short course RT in 25 grain 5 fraction during 1 week followed by immediate surgery. It is a category 1 grade A recommendation. Short course RT with delayed surgery is also an alternative to conventional short course RT with immediate surgery, offering oncological outcomes with lower positive complication. So what is the ideal timing of interval? What should be the ideal time between the surgery, between the radiation and the surgery? So for a long course RT, the ISMO guidelines suggest 6 to 8 weeks and suggest 5 to 12 weeks. So why you should delay the surgery? For tumor regression. And when short course RT, the surgery is performed 7 to 10 days. Patient should, with a pathological complete response, there is a best local control and improvement in the overall survival. So if in a short course, if it is oncologically safe to extend the interval between the RT and the surgery, then we could add consolidation chemotherapy to increase the outcome. So with this hypothesis, the POLISH trial was designed, which had a short course RT, wherein the short course RT was given 5 grain 5 fraction, followed by 3 cycles of FOLFOX chemotherapy. And another arm, it was long course RT, 50.4 grain 25 fraction with chemotherapy. So around 515 patients were randomized. So the primary endpoint was the radical surgical resection. So there was no difference in the results with the radical resection rate. There was no difference in the toxicity, no difference in the survival. The short course RT followed by chemotherapy versus NSCT did not have difference in the endpoints, that is overall survival, local control disease, the distant metastasis and preservation rate. But there was a better downstaging compared to the long course RT. So in the Polish one trial, in the long course RT, we had seen that the pathological complete response was around 16% versus the short course RT. But now with the introduction of the consolidated chemotherapy in the preoperative arm, the pathological complete response in the short course RC was much better than the CTRT arm. So now this is the first ever meta-analysis which has been published recently in Acta Oncology, which is the new adjuvant short course radiotherapy with consolidated chemotherapy for locally advanced rectal cancer. It's a systematic review and meta-analysis. So here they had included around 6 randomized trials, and the patient population was T3N0 and node positive. So short course RT followed by chemotherapy as a new adjuvant therapy was compared with long course CTRT. The primary outcomes were pathological complete response, overall disease-free survival. So you can see here that it favors the risk ratio favors the short course consolidated chemotherapy arm compared to the long course arm. Also, the 3-year
We have 7 more minutes.
Yeah. So 3-year survival was better in the CTRT consolidated arm. So now you can see that the short course chemotherapy followed by chemo improved tumor response. The overall survival was comparable. So what are the factors in determining them? So what are the factors determining the treatment approach? So in T1 and T2 tumors with threatened CRM, high rectal, good quality TME should be done. For T2 and T3 stage disease, in the mid rectum, the short course RT followed by TME should be done. For T3B or high disease node positive and low lying tumors, bulky tumors with threatened CRM, long course CTRT followed by TME after 8 weeks suggested. And in elderly patients with poor performance status, short course RT followed by this suggested. So coming to the techniques, so the previously all the trials in the 90s era use a conventional radiation therapy. Today, the 3D conformal radiation therapy is considered the standard. However, with the advent of the modulated radiation therapy with Imrt and VMAT, with a better dose distribution, we could reduce the dose to the normal OARs. So this is the dose distribution of Imrt versus 3D CRT, where you can see that the 50% dose includes a head of the femur, wherein it is a very conformal precisely in the Imrt arm. So that this can reduce lesser toxicity to the bowel, large bowel, small bowel, and to the head of the femur. So recently, there has been a meta-analysis published where it has compared intensity modulated radiation therapy along with the CTCRT, comparing the toxicity. So in this trial, 6 trials were included, around 859 patients. Wherein the IMRT showed that the grade 2 or more toxicity was significantly reduced in the IMRT arm, and the lower incidence of grade 3 or more toxicity was significantly reduced in the IMRT group compared to 3D-CRT group. David et al. And T et al. Also compared IMRT with its conformal radiation therapy. They also found a similar thing that IMRT was significantly associated with lesser toxicity and improved partial response. So what does the ASTRO 2021 guideline recommend? So it recommends that the pelvic MRI with rectal protocol should be recommended for preoperative clinical staging. For patients with stage 2 and stage 3, new adjoint RT is recommended. So whenever in rectal cancer, the RT is indicated, it should always be preoperative rather than postoperative. And the relative indications are when the patients with stage 2 or 3 cancer, adjuvant having the lower risk, the multidisciplinary team discussion should be done for this kind of cases. And in patients wherein the tumor in clinically T1 or N2 lying closer to the sphincter, who needs APR, neoadjuvant CTRT is recommended. So, along with the neoadjuvant regimen, both long course and short course are equivalent and can be used. So the conclusion is that preoperative RT is better than postoperative RT. The short course RT is equivalent to the long course RT. Before starting any neoadjuvant treatment, careful evaluation of the extent of the disease is must in the MD by the MD. So thank you very much, and for acknowledgement, Dr. Shahid Tanvir for sharing his slides, some of the slides. Thank you. So now I introduce the next speaker, Dr. Preetham Kataria, who will be talking on the chemotherapy approaches in concurrent and adjuvant setting.
Yeah, good evening all. Thank you, Dr. Naseem, for the kind introduction. So I'll be speaking on chemotherapy approaches in concurrent and adjuvant setting. And I'll be speaking primarily on neoadjuvant chemotherapy, adjuvant chemotherapy, and the total neoadjuvant treatment. And as we know that the treatment of the rectal cancer has evolved from surgery to neoadjuvant chemoradiation, definitive chemoradiation, and chemotherapy. And the aims of the rectal cancer treatment has been to improve the survival, reduce the risk of local and systemic recurrences, improve quality of life, and sphincter preservation. And this is the AJCC standard staging of the rectal cancer. And so rectal cancers would be classified localized cancers, locally advanced cancers, and the advanced malignancies. So T3, T4, N+ disease would be called as locally advanced cancers, and they will qualify for the neoadjuvant therapy. So surgery is the cornerstone in the management, but there's a high risk of local recurrences in the rectal cancer because of their close proximity to the pelvic structures, absence of serosa, and technical difficulties with respect to the obtaining the wide surgical margins. So if we do only surgery, time and again, the trials have shown that there's a increased risk of local recurrences, and the different trials, right from the NACBP trial, what we can see is the risk of local recurrences is between 25 to 40 or 46%. So what changes by adding radiation, as Dr. Naseem has pointed, there's decrease in the local recurrence rates, and the different trials, the MRC, the NACBP trial, showed that there's a reduction in the local recurrences by addition of radiation to the surgery arm. So the topic, chemotherapy, is there any role of addition of chemotherapy to the radiation in the preoperative setting? Definitely. The 4 trials, the AORTC, the FFCD, the POLISH trial, and the GRICA trial showed that the addition of chemotherapy to the radiation in the preoperative setting improved the pathological complete response rate, and there was improvement in the 5-year local recurrence rate. And this was something very much important to decide the addition of chemotherapy. There was a meta-analysis which showed that the addition of chemotherapy to the radiation improved the local control, albeit there was increased toxicity, but it was manageable. There was a second Cochrane review which showed that the preoperative chemoradiation versus radiation in the stage 2, stage 3 rectal cancers had a high rate of PCR rate and improved local control. So what are the advantages of adding chemotherapy to the radiation? It helps in control of systemic micrometastasis. It leads to the sensitization of local RT, and it leads to the increased rate of pathological complete response rate and the reduction of the local recurrences. So when we were treating the locally advanced rectal cancers, there were questions how we can improve more PCR and we can decrease the local recurrence rates. So was there any role of addition of any other therapeutic regime drug like oxaliplatinum? So 5 trials, ACCORD, STAR, NACBP, the PETAC trial, and the CAO trial, which looked at the addition of oxaliplatinum to the standard CAPE or the 5FU regimen along with radiation did any benefit? Well, it did not show any improvement in the PCR rate. There was no improvement in the local recurrence rate, but there was increase in the toxicity. So a landmark paper in the JCO in 2014, which looked at the 5FU versus oral capecitabine versus the 5FU or capecitabine with oxaliplatin in the preoperative regimen, did not show any benefit in the terms that the 5FU or oral capecitabine was enough in the preoperative setting to improve the PCR rate and the local recurrence rate. However, addition of oxaliplatinum led to more toxicities and there was no benefit. So to summarize, that concurrent chemoradiation would improve the PCR rate and reduce the local recurrence rate, and the addition of oxaliplatinum did not show any remarkable benefit. So these were the new adjuvant therapy indications: T3, T4 lesions, T3 N0, depending upon the depth of extramural invasion, T1, T2 lesions with positive node, low situated lesions to save the sphincters, and invasion of the mesorectal fascia. So coming to the second topic, that is adjuvant chemotherapy. So the NCCN guidelines just suggest the adjuvant chemotherapy for those patients who have received the preoperative CTR. However, there is something new to that there are 4 RCTs, so the EORTC, the ICNRT trial, the Proctor's trial, the Chronicle trial, and the one meta-analysis. So we divide those patients who have received the preoperative CTRT and those patients who have not received the pre-op CTRT. Those patients who have received the pre-op CTRT, so the first trial, the ICNRT trial, which looked at the addition of adjuvant chemotherapy post-surgery, those who have received the pre-op CTRT, there was no improvement in the 5-year overall survival rate or the 5-year disease-free survival rate. The Dutch trial, which was closed prematurely due to slow accrual, again, it did not show any improvement in the 5-year local recurrence rate or 5-year metastatic free survival rate. The Chronicle trial again looked at the same, and it again failed to show any benefit in the terms of the 3-year overall survival or the 3-year disease-free survival. The EORTC 22921 trial again looked at the different chemotherapeutic regimens in the adjuvant setting, and again the 5-year results didn't show any benefit in the terms of the 5-year disease-free survival rate or the overall survival rate. So the 4 trials with respect to the adjuvant chemotherapy did not show any DFS or the OS benefit, and so there was another meta-analysis which looked at the same question to be answered, and again it included those patients who had a pathological stage 2, stage 3 cancers, and what we can see is there was only benefit in the terms of OS. Those who had the tumor 10 to 15 centimeters above the anal verge had a disease-free survival if those patients who had again the tumors 10 to 15 centimeters above the anal verge. And what we can see is the distant recurrences did not differ in those 2 arms, whether they received chemotherapy in the adjuvant setting or they didn't receive the chemotherapy. However, there were 2 trials, the ADORE trial, which looked at the use of FOLFOX in the adjuvant setting and those patients who received the pre-op CTRT, and there was a benefit in the terms of the adjuvant chemotherapy arm, and on the Kaplan-Meier analysis, what we can see is there was a good separation of the curves. The German study again used adjuvant FOLFOX, and what we can see is there was a 4.5% absolute benefit in the terms of the 5-year disease-free survival rate or the and there was some numerical benefit in the terms of the 5-year overall survival. So those patients who have not received any CTRT due to some reasons, the Cochrane analysis, which was a meta-analysis, which looked at the post-operative adjuvant therapy in those patients who have not received any pre-op CTRT. And what we can see is there was improvement in the disease-free survival, as well as it was those patients who had received the adjuvant chemotherapy had an improvement in the overall survival. So if you look at the summary of the trials, EORTC, the Italian, the Chronicle, and the Proctor trial were negative, and the 2 meta-analyses were negative. However, the ADORE trial and the German study were positive. So to conclude in the terms of the adjuvant chemotherapy, those patients who have not received pre-op CTRT should receive adjuvant chemotherapy, while those patients who have received pre-op CTRT, for stage 2 or stage 3 pathological stage 2 or stage 3 cancers should receive adjuvant chemotherapy. However, those who have a pathological complete response rate after the CTRT should be individualized and be discussed with the patients about the adjuvant chemotherapy. So new kid in the block, that is a total neoadjuvant therapy. So what is the reason to use total neoadjuvant treatment? So the standard of care has been the pre-op CTRT followed by surgery followed by adjuvant chemotherapy. However, though a standard treatment led to the reduction in the local recurrence rate, it was just not sufficient to prevent the distant metastasis, and there was no improvement in the disease-free survival or the overall survival. The PCR rates were just 10 to 30%, and so distant metastasis always remained a concern. Also, less than 50% of the patients received adjuvant chemotherapy because they were not better or they were not fit post-surgery. So the rationale for TNT is improve the treatment compliance. There is an effective downstaging of the primary tumor, and it helps in the facilitation of the organ preservation and helps in the improvement in the PCR rates. Also, it takes care early of the micrometastatic disease and may improve the distant metastasis-free survival. However, there were some concerns. There could be some toxicity because of usage of chemotherapy immediately after the chemo radiation, or also there could be delays to resection, which may lead to potentiation of local progression. So this was the ASCO presentation in 2014, which initially started the talks about the total neoadjuvant therapy, and it showed that there was improvement in the PCR rates to the tune of 33%. And there was the expert and the expert C trial again in the ASCO 2014 presentation, which led to the improvement, which showed that there was improvement in the PCR rates. The two landmarks trials, the Prodigy and the Rapido trial. So the Prodigy was the first trial, which looked at the pre-op CTRT followed and the neoadjuvant chemotherapy followed by surgery. That is a total neoadjuvant therapy. And what we can see is there was improvement in the 3-year disease-free survival and the 3 years metastasis-free survival, and the p-value was significant. The toxicity was more in the arm where the total neoadjuvant therapy was given. However, it was manageable. The Rapido trial was the second trial, which looked at the pre-op the total neoadjuvant therapy versus the standard therapy of CTRT, surgery followed by the adjuvant chemotherapy, and it was a randomized multicentric phase 3 trial. What we can see is there was benefit in the terms of the distance treatment failure, in the terms of the there were less treatment failures in the term of the experimental arm. There were less, and there was improvement in the survival in the terms of those patients who received the total neoadjuvant therapy. There was a meta-analysis which was published in the Oncology Journal, and what we can see is the total neoadjuvant therapy was compared with the standard neoadjuvant chemoradiotherapy followed for the locally advanced rectal cancer, and this systemic review showed that the PCR rates as well as the disease-free survival was improved in those patients who received the total neoadjuvant therapy. And the recent NCCN guidelines have included the total neoadjuvant therapy in their guidelines. There are a few shortcomings of TNT. Toxicity is some concern, and we require more long-term survival data for the same. So to summarize, the careful assessment of the patient has to be done before deciding upon the treatment. Chemosensitizers could be 5-FU or capecitabine. A role of adjuvant chemotherapy needs to be discussed. TNT is now been accepted as a standard, and since it looks promising in the terms of the PCR rates and the disease-free survival rates. Now I would like to welcome the next speaker, Dr. Paresh Jain, who is a consultant surgical oncologist with special interest in the colorectal surgery at Sir H.N. Reliance Foundation Hospital. Over to you, Dr. Paresh, sir.
Thank you, Pritham. Good afternoon, everyone. Pritham, you want to stop your slide share? Yeah. Good afternoon, everyone. Yeah. Firstly, I would thank Dr. Haribhakti and Dr. Prasad Dandekar, who have been very instrumental in organizing this webinar on rectal cancer. Rectal cancer is always in debate and always been evolving since last decade or two. And hence, that's what when Prasad decided to come up with this topic, and we charted out this program. Again, a thanks for all the participants for joining on this weekend and not taking much time. I'm moving ahead. So my role in today's presentation is mainly to see how surgery has evolved with regards to rectal cancer, moving from an open surgery to laparoscopic and robotic and natural orifice surgeries. Couple of slides on each of them. Amol, my slide, I'm not able to change the screen.
One second, I'll come.
Sorry.
Sorry, Paresh, what is the problem?
I'm not able to go on to the next slide.
I'm coming to your room.
Sorry. Where is the cursor? Yeah, that's what the problem with the Mac. Okay, sorry for the bit of a technical issue. So these are the points we're going to discuss as we move through the slides. Basically, a changing trend in the management of rectal cancer, the various gamuts of surgery, lap, robotic, and natural orifice. And again, definitely what's available in India. Sorry, bit of an issue again.
Paresh, can I share the slides from my end?
Yeah, you have the slides with you?
I have them with me.
Okay, you can see as of now. Yeah, okay. So regarding the statistics, Dr. Haribhakti has already briefed us in the start that, according to the latest Globocon, this is a very common cancer, third common cancer. And this is where we want to make a difference between in the incidence and mortality and try to decrease this ratio by decreasing the mortality. And that's what we want to focus on in a developing country. So we'll just discuss again about the various surgical advancements. So laparoscopic colon and rectum surgeries, basically we all know laparoscopic rectal surgeries do have their own advantages of early recovery, less pain, and again, we all know the bottom line, they have to be oncologically safe. So instead of large 15-20 centimeter cuts with a laparoscopic surgery, we have about 4 or 5 1 centimeter cuts, which gives us an added advantage of getting an early recovery with less complications. Apart from using laparoscopic rectal surgeries for elective cases, people have moved on for other indications as well. Like this study from UK has showed an advantage of laparoscopic surgery for an octogenarian population above 85, which is considered to be safe and feasible again. They have been using laparoscopic surgeries for in an acute setting as well, and it has shown that the 30-day postoperative complication rate is less as compared to the laparoscopic arm as compared to an open surgery. And as we all know, the risk with any small abdominal surgeries is the risk of small bowel adhesions and obstruction. And through this meta-analysis, it has been proved that with laparoscopic surgery, the rate of small bowel adhesions and subsequent surgery for same has significantly gone down. So we have seen enough evidences to say laparoscopic surgery for rectal cancer has its own definite advantages. And again, there are various trials to support the same.
Paresh, just hold on. I think there is some problem with the slide sharing.
Don't need to share.
Yes, there's some share icon coming. Yeah, we can't see the slides. Yeah, now okay, perfect. Yeah. Make it on the slideshow.
Yeah, we can see it now. Yeah.
Seen now?
Yes, it's seen now.
Perfect.
Okay. So I'll just start from laparoscopic surgery because that's where we are working on. So early recovery, less pain, and oncologically safe. These are the kind of 3 points which we have
Paresh, which slide you want me to be on? Currently, we are on the slide which shows the statistics.
Oh, I am on slide number 10, if you can. The next one, yeah.
Is this the right slide?
Yes, yes.
Okay, perfect. So just let me know when you want me to move to the next.
So full screen mode. Oh.
Okay. Well, the play button. You okay?
Paresh, with the play button, I'm getting some problem. I think this is fine because then I can't see the cursor and I can't.
Okay.
Yeah.
Okay. So we will continue like this. It's okay. Yeah. So with the laparoscopic surgery, we have the advantages of early recovery, less pain, and definitely oncologically safe. So instead of large 15, 20, 30 centimeter cuts, we have these small cuts. And it has been shown that the risk of wound complications, bowel function returnability, and the return to normal functionality is much faster with laparoscopic surgery. Next slide. Laparoscopic surgery, apart from using for normal rectal cancer surgeries, has also been proven to be beneficial in an octogenarian population by the study from UK, which says it has added advantage, kind of is feasible and safe in an age group of 85 and above. Also, we've been using laparoscopic surgery for in an acute setting, and for rectal surgeries in an acute setting, and there is the 30-day post-operative complications were less for a laparoscopic as compared to open surgery. As we all know, the risk of small bowel obstruction and adhesions after open surgery is too high, and with the laparoscopic surgery, there are meta-analysis which has said that this risk significantly goes down. Next slide. There's a, okay. So, okay, the previous one. So basically, I'm sorry, I couldn't show you the text behind it, but basically it says that the various trials involved in this surgery, in the laparoscopic and robotic surgery, the Color and the Lorec trial, which has supported the same. Now, okay, thanks for that. So this was a young 42-year-old gentleman who came to our clinic at HN Hospital when I came back from UK. And so the first case we did here, he was a case of familial adenomatous polyposis coli, along with rectal cancer. So he had a laparoscopic total proctocolectomy. We did an ileoanal pouch and a diversion ileostomy. So after the laparoscopic surgery, he was kind of eating on a normal diet by 24 hours, pain controlled with simple analgesics like paracetamol. And by day 6, he was discharged from the hospital. So that's kind of the advantage of the laparoscopic surgery, which has been proven over time. Next slide, please. Another added advantage of laparoscopic surgery is for the low rectal tumors, where in an open surgery, we always find the last part of the rectal resection is always relatively a blind procedure. And that's why there's always risk of getting this surgical waste, and thereby the risk of positivity, CRM positivity. However, the laparoscopic surgery, you are able to produce a cylindrical specimen, giving an intact CRM, thereby decreasing the local recurrence rate. So that's the second added advantage of laparoscopic surgeries. Now, the science didn't stop here. Next slide, please. We moved on to the evolved from laparoscopic to robotic surgery. And in the robotics, the next slide, please. Yeah, can we move? Okay, so in a robotic surgery, there are three components. The A is the surgeon's component, the surgeon's console, B is the patient console, and C is the visual cart. And from the major advantage of a robotic surgery is the arms which can be seen. Can you get that image up, please? Yeah, thanks. Is the major advantage is the kind of the wrist-like movement inside the abdomen, which is restricted with a with the laparoscopic surgery. So the surgeon normally, in a nutshell, for the students who are attending the webinar, basically the surgeon sits on the console, that is A, the patient is on the patient cart, and with the help of an Ethernet connection, they are connected via cable line. And when you move the console, when you move the master console on the surgeon's console, the robotic arms do the action inside the abdomen. There's a visual cart, which is the cart C, which is for the attendees inside the theater, for the staff as well as the assistants who can see and guide you through the visual cart, which is an interactive screen. Yeah, next slide, please. No, the next slide. Next slide, yeah. So we all know the robotic surgery is a part of evolution, and what we have seen, the advantages of robotic surgery is the precision, the 3D vision, and definitely the 7 degree of motion. Though as of now, the disadvantage is the cost, because as of now, today as we talk, Intuitive is the only robot available, and other ones are now coming up into the market, and definitely the cost will go down. We have enough scientific data to support the same. Next slide, please. Okay, I'm sorry for this thing, but yeah, so the first slide, yeah, that one. So this is a meta-analysis on robotic versus laparoscopic surgery. And this meta-analysis, published in 2017, had 2 randomized trials and 22 non-randomized trials with 1,500 patients and roughly 1,500 and 1,800 patients in robotic as well as the laparoscopic arm. And it has shown that the estimated blood loss, hospital stay, conversion to open, they're definitely less with the robotic surgery. However, the oncological accuracy and the complication rates, there was no significant difference between the lap and the robotic surgery. Another study published in 2018 compared the short-term outcomes of robotic versus laparoscopic surgery. And it has shown that the major difference was the return of bowel function, which was much earlier with the robotic as compared to a laparoscopic surgery. Again, probably because of less tissue handling. Another personal experience by 502 patients from UK. The robotic, can you get the lower slide upstairs, please? The last, yeah, this one. So that showed, that basically compared the conversion rate and the from robotic to open and lap to open surgery. And the conversion rate was much less with the robotic surgery as compared to an open surgery. However, the ROLAR trial, which was published in 2019, did not show any statistical difference between a robotic versus the conventional laparoscopic or open surgery. This is the latest randomized trial. However, it's a non-inferiority trial, so probably a long-term follow-up is still needed to get a conclusion onto the same. Next slide, please. So the major advantage of robotic surgery is basically to assess those places which are difficult to access via the laparoscopic approach, especially the deep pelvis, the low rectal, ultra low rectal tumors, and for complex tasks like intracorporeal suturing, thereby decreasing the learning curve. However, the major downside, I would still say, being a robotic surgeon of the robotic surgery, is the lack of tactile feedback. With the newer robot coming into the market, this gamut of fallacy has been trying to take over, trying to be rectified, and probably with the newer robot, this will definitely go down. The cost involved will also go on a downslide, which is now going to go down with the newer robot coming into the market in 2 months' time. Next slide, please. So that was the first robotic surgery patient we did in the hospital about 3 years back. He was a young chap of 54-year-old with rectosigmoid tumor, and that was the port placement done. That's my team in the background. Again, Dr. Marzi is my co-colleague. He's a surgical oncologist and has always been instrumental during all of my surgeries. And along with so as I said, robotic surgery is a team approach rather than one-man show. The OT staff, the nursing staff, the technicians, and the nurses and the anesthetists, they all have a dedicated robotic training, and then they are involved into this treatment. Next slide, please. Can you play this video? This is a video to show the advantage of a robotic surgery, how basically it shows how you can go around in each and individual vessel, the clarity of vision, and the finesse with which you can apply. You can see your instruments and your structures very well. If you can see in the right hand corner, the lower right corner is the hypogastric plexus, which is close to the IMA, and that's what can be preserved, thereby preserving the bowel function. If you can move this, Prasad, if you can move this slide away, there's a small video behind this as well. Thank you. So this is just to show the clarity of vision, and with what ease you can mobilize the colon. You can identify the inferior mesenteric artery very well, isolate it completely under vision. That's a couple of robotic arms which we use to open up the peritoneal plane, a gentle dissection, more of a bloodless surgery. You can see the areolar fibers, what we call as the angel fibers. They are seen so precisely, which may not definitely never seen in my open era days. And once we mobilize the peritoneum, you can definitely more easily identify the inferior mesenteric artery, the pedicle, and the ureters. Yeah, so that's what you can see, the pedicle there, the ureter in the background, which can be easily looped across and retracted back into the peritoneum. Okay, next slide, please. So this was the patient. Again, he was eating and drinking within 24 hours, pain under control with just paracetamol-like medications, and again discharge on day 5. Next slide. So always the question comes, why the robot? Why did we evolve? From if lab was good or if robot open was good, why did we move on? So as we know, we have today's era, we have a landline phone, we have a smartphone, as well as we have a standard Nokia phone as well. So in today's era, you've got to select your case well and select where do you want to offer them a laparoscopic or a robotic surgery, or it's too advanced and give them only open surgery. So the entire gamut of open, lap, and robotic has to be in your armamentarium, and you should have to select your case well before you offer it to them. Just next slide, please. So just next again. So this is just to say, even the open surgery has advanced, and we have moved from about 5 centimeter distal margin we have moved down to coloanal anastomosis, intersphincteric resections, cytoreductive surgeries, plus minus HIPEC, and synchronous resections for the liver met along with the rectal cancer surgeries. Next slide. So these are the few of the cases we did a cytoreductive surgery along with the entire specimen extraction in the hospital. So just to say that even open surgery is advanced, not that everybody should only undergo lap or robotic surgery, but there is a role of open surgeries with the proper case selection. So yeah, next slide, please. So now coming on to the newer gamut, that is the natural orifice surgeries, the transanal surgeries. There are a couple of them into this armamentarium. The TEMS, that is transanal. Next slide, please. That is transanal endoscopic microsurgery. Can you move the images away, please? Thanks. So basically, you have to select your criteria very well. These are small lesions, less than about 3 centimeters, not occupying more than 40% of the lumen of the rectum, and they are well or moderately differentiated with no lymph nodal invasion. So basically, in this, if you can get the white picture upstairs, yeah, the patient is in lithotomy position. There is a wide bore proctoscope inserted inside the rectum under anesthesia, and through that we put in the camera and few TEMS related instruments. Can you get the other image up, please? So as you see in this, with these laparoscope, with the camera inside and 2 instruments inside, you can resect these tumors. And next slide, please. And this is what we kind of resect. These are mainly sessile flat tumors, which are kind of early rectal cancers. They are mounted on a sponge or a cork base and then sent for testing. Now, however, as we know, surgeons are relatively resistant to change. Hence, because this was a big instrument, the surgeons were not really readily acceptable to learn it. We evolved further. And the next slide, please, comes the transanal minimal invasive surgery. So basically in this, the major difference was instead of the TEMS scope, we use here something called the gel point port, which is the blue one, which is seen in the left corner. And once the gel port is inserted into the rectum, can you show the image in the background in the front if possible? Yeah. So in this, the gel port is inserted, and through this, we put our normal laparoscopic instruments as compared to the special instruments which are angulated instruments which are used for TEMS. And through this, the similar surgery is performed to get a better outcome, and local diseases can be resected through transanal surgeries. Next slide. So if you see again, and we all work on an evidence-based practice, and TEMS surgery has been shown that the sphincter preserving is a high quality TME. The anorectal functions are well preserved, and with the Colorectal trial comparing the transanal TME versus the laparoscopic TME. I'll leave that topic to the end for Dr. Ashwin to discuss, because he's going to discuss on TME. Next slide. Next one. Yeah. So at current scenario, what are the services available in India? And fortunately, at the next slide, please. At HN Reliance Hospital, we have the entire gamut of surgery available, ranging from high-end open surgeries to robotic surgeries, targeted therapies, as well as the latest edition of radiotherapy. That's my hospital in the day and in the night. And these are actual images, not pictorial. And so the last slide. So the take-home message: everyone should be offered keyhole surgery in today's era. No compromise on the oncological outcome. At any time you feel that things are not possible through a minimal access approach, probably have a low threshold to convert it to an open surgery, because that's what the surgery is for. It's for good oncological clearance. Again, case selection is vital. Just because you know the robotic, you should hammer it, doesn't make sense. Patient comfort and early recovery is a necessity, and that's why we are evolving. Last slide. Thank you. So that's me in my 3 avatars: open, robotic, and laparoscopic surgery. And thank you for all your patience. Thank you, Prasad, for running me through this slide. And apologies to the attendees for couldn't really run through my videos myself, but Prasad did a great job. Thanks a lot, Prasad. So probably we'll keep the questions to the end for the panel discussion. We move on to the next topic, that is immunotherapy and targeted therapy update by Dr. Anjana Sainani, who is the consultant medical oncologist at HN Reliance Hospital. And over to you, Dr. Anjana.
The host has stopped my video.
Anjana, you should be able to share now.
Okay. Yes. Good evening, everyone, and thank you, Dr. Paresh Jain, for taking us through the modern ways of uh, attacking the colorectal cancers in the best possible manner. And I would like to thank the hosts, Dr. Vijay Haribhakti, Dr. Prasad, Dr. Pritam Jain, and Dr. Paresh Jain for giving me this chance. We had a very good talk by Dr. Naseem on radiotherapy and Dr. Pritam Jain on chemotherapy. But here and now we move on to something which, so I'll just go to wherein the patients have actually failed the initial therapies with local treatments, radiosurgery and chemotherapies, multiply treated, and they are the advanced cancers. These are the patients wherein we need to think beyond the regular pathways, wherein we can attack and give them a survival benefit. The guidelines and recommendations for target and immunotherapy in rectal cancer is basically same as of colorectal cancer. And as I just said, these are the therapies which we apply when we have kind of exhausted chemotherapies and the patient has metastasized either single lesion or multiple lesions and need further avenues to get the survivals. So what are these new targets? As we have understood the molecular biology of colorectal cancers, we have understood many molecular pathways, certain genetic mutations, and the immune environment of these colorectal cancer cells, which actually give them the cancer cell a survival benefit, overcomes the protective mechanisms of the body, overcomes the drugs which we are trying to apply. So it is very interesting and important to understand what are these. Ultimately, the goals of therapy in metastatic colorectal cancer is we want response first and foremost. Sometimes we want a metastatic site to be amenable to surgery and give them a relief, or sometimes primary tumor needs to be palliated. So we need some kind of response even in metastatic situation. Betterment of progression-free survival, overall survival. At the same time, the drugs should not be toxic. One should have better quality of life. And at the same time, the cost effectiveness has to be weighed. So as I said, a colorectal cancer cell survives by virtue of many transmembrane proteins it possesses on its cells and the way it communicates with the T cell and makes everything favorable towards its own growth. So these are the major pathways which have been very well understood, applied for the therapies. The EGFR pathway, epidermal growth factor receptor pathway, the VEGF pathway, the HEF-c-MET pathway, and certain immune checkpoints on the tumor cells, which allow it to grow. So as we can see, the EGFR receptor and VEGF receptors and MET, when they get activated, there's a signal transduction pathway downstream in form of RAS, RAF, MEK pathway, or PIK3, AKT, mTOR pathway, which ultimately gives signals to the nucleus to produce certain proteins which are more pro for tumor proliferation and its survival. EGFR is overexpressed in 25 to 77% of colorectal cancer. This was one of the oldest marker which was detected and found to be associated with poor prognosis, especially in the left-sided tumors, colon tumors. And as we know, it works through many pathways, and this itself became the first ever target therapy almost 20 years ago. How we attack these EGFR is through the monoclonal antibodies. These are the biological agents which could be murine, chimeric, partly humanized, or fully humanized. And the commonest ones are the anti-EGFR and anti-VEGF. Anti-EGFR are the cetuximab and the panitumumab, and anti-VEGF is bevacizumab. These were the initial ones which brought the change or brought the change in the whole graph of metastatic colorectal cancer, because they easily cause the degradation of these receptors on the cancer cell. Cetuximab, as I said, it was the first chimeric monoclonal antibody approved in 2004 when it clearly showed overall survival and progression-free survival in the chemotherapy failed patients. So Crystal 3 trial combined it with FOLFIRI treatment, and we could see the improvement in the progression-free survival, and we also use it during maintenance after FOLFOX regime, and it is continues to give us benefit even after FOLFOX. Panitumumab had the advantage that it was a fully humanized monoclonal antibody, and the PRIME trial, wherein FOLFOX combined with the panitumumab, offered a progression-free survival and overall survival benefit with a almost 22% increase in the survivals. And now we even use panitumumab for maintenance along with 5-FU leucovorin combination after FOLFOX regime is over. And it has given progression-free and overall survival benefit. ASPECT trial was one of the largest trial which then compared both the drugs which were now available to us, which one is better over the other, but it was a large meta-analysis, and it just showed that response rate wise, progression-free period wise, or overall survival wise, neither of the drugs was inferior or superior to each other. We could use either. But then we had to weigh the side effect profile of the drugs and the cost of the drugs. Like in cetuximab, we usually see skin rash or cell-mediated immune reactions, and in panitumumab, hypomagnesemia is something which you need to manage. And if cost effectiveness-wise, cetuximab is more expensive than panitumumab. So then came, once EGFR was conquered, we had enough antibodies, but as we go ahead in the treatment, in the eventuality, patient would still relapse or metastasize further. And we would find anti-EGFR therapy failure. And that's how we discovered that there are some somatic mutations which are very prevalent in colorectal cancers, which are responsible for this anti-EGFR resistance. Out of these mutations, Keras and NRAS mutations are the most important, and they are predictive of response to cetuximab, panitumumab like monoclonal antibodies. Keras, once it is mutated, it causes increased signaling despite upstream EGF inhibition. So even if we block EGFRs and we feel we are blocking it, but then Keras mutation is independent of that, and it causes further downstream BRAF MET signal pathway is stimulated, and more trigger goes to the nucleus to produce cancer cells. Most of the mutations which are, now these are very common, almost 50 to 80% of the colorectal cancers will harbor Keras and NRAS mutations, and that is why we find the treatment can be very difficult in these patients. Mutations in codon 12 and 13 of exon 2 of Keras gene confers resistance to anti-EGFR therapy. Mutations in exon 2, 3, 4 of NRAS and exon 3 of Keras are partially sensitive, so they have just less benefit with anti-EGFR therapy. And nowadays, more and more mutations are being discovered, something like G13D, which could be related to resistance to anti-EGFR therapy. Next mutation, which is beyond Keras, is the BRAF V600E mutation, though it is not so common, but it is very problematic, as we can see that after EGFR EGFR block, RAS is also wild type, still we do not get response because BRAF is mutated, and it just, once it is mutated, it gives a 500-fold increase in the kinase activity, and it confers resistance to the EGFR inhibitor as we keep going ahead in the treatment. So this is highly a marker of a very poor prognosis. And today we have BRAF inhibitors like encorafenib and binimetinib, which are active to block the BRAF mutation and allow the treatment. Sorry, my slide is getting covered up. So Keras mutated patients throughout all the trials, multiple trials have shown how Keras mutated patients respond poorly. And even when cetuximab is added to FOLFIRI regime as a very good regime to overcome to attack the EGFR pathway, as we can see in BRAF wild type, the treatment, the outcome is definitely improved with cetuximab. It is also improved in BRAF mutated patients, but then result is not as good as in the wild type. So Keras mutation and BRAF mutations are the two main mutations which are the trouble creators. And as we can see, the overall survival is totally based on Keras, NRAS, and BRAF status. Wild type tumors are the best behaving ones, where we get overall survival of 42.7 months, followed by Keras mutated 32 months, NRAS 25.6 months, and BRAF mutated is the worst mutation, giving overall survival of 14.9 months. And this just shows how difficult it gets to treat these patients when they have these kind of mutations activated. When we come to VEGF monoclonal antibodies, VEGF pathway is basically, when it is stimulated, it causes tumor initiation, growth, and metastasis through angiogenesis or neovascularization, because these are the vascular endothelial growth factors when they are stimulated. So these are also very active in colorectal cancers. These were also discovered many years back, and then came line of drugs which could block these these receptors, namely bevacizumab, ramucirumab, alpha-bacept, and regorafenib, which is a tyrosine kinase inhibitor. All these are VEGF inhibitors. But the wonderful thing about these VEGF inhibitors, especially like bevacizumab, which has been most well studied, applied, that it works across all kinds of Keras, whether it's wild type or whether it is mutated. It will be effective in all these cases. It will be effective in both left and right-sided colorectal cancers. And it can be combined with FOLFOX or FOLFIRI, unlike EGFR inhibitors, wherein we prefer FOLFIRI with cetuximab and FOLFOX with panitumumab. So here we don't have any regime can be combined with this bevacizumab. And more so, we can use bevacizumab in the first line, in the second line, and even in the maintenance therapy alone or in combination. So it is kind of a very general antibody, and it is always available till we get any results of other markers. And another interesting part is that bevacizumab works even beyond progression. This benefit we don't see with many drugs, because most of the chemo drugs, there's some resistance coming up. Bevacizumab by and large works even beyond bevacizumab progression, as we can see how overall survival, 1-year survival, and overall even after the first year is better with bevacizumab, is maintained with bevacizumab. These are the other VEGF inhibitors like aflibercept, which was combined with FOLFIRI. And it has given a moderate increase in the survivals, which again, it is used beyond bevacizumab use. When bevacizumab is failed in the second line or the subsequent therapy, this can be used. Same way, ramucirumab also combined with FOLFIRI. And when compared with FOLFIRI alone, it shows a better overall survival. And again, it is used in the second line or subsequent lines beyond bevacizumab. Her2 amplification is another mutation, another genetic alteration seen in colorectal cancer, present in 3% of the cases. These are usually RAS and BRAF wild type, and surprisingly, they are not responding because they are Her2 amplified. These are also, again, left-sided tumors, and they are predictive of resistance to anti-EGFR therapy. We do not routinely test HER2 unless we really feel the need of looking for newer therapy. And all these trastuzumab, lapatinib, pertuzumab, which are the NT2 therapies, are still investigational. Coming to immunotherapy, now how immunotherapy is one of the modalities for metastatic colorectal cancer is first to understand that the tumor cell has these checkpoints, immune checkpoints on its surface like PD-L1, MHC class 1 and B7, which engages the normal T cell, which is ready to fight, but it engages it such ways through the ligands like PD-1, peptides, and and CTLA4 engages it such a way that it numbs the T cell, causes anergy, and T cell stops fighting the tumor cells. So when this was discovered, which is of course we have learned about immunotherapies through other immune diseases like melanoma, lung cancer, and even colorectal cancers have enough T cell engagement this way so that it can continue to grow. So once we use these antibodies and unlock this engagement of T cell with the tumor cell, the T cell again becomes active and starts attacking the tumor cell. Another thing which makes colorectal cancer cells very immunogenic is because of the microsatellite instability and mismatch repair. As we know, whenever there's a DNA damage, an intact DNA mismatch repair mechanism repairs it, and these are microsatellite stable cases. But when this mismatch repair mechanism is deficient in the colorectal cancer cell, there are many microsatellites which accumulate and makes the whole genome very unstable. And this instability of microsatellite, which is also called as microsatellite instability, is very high, or the MMR, the mismatch repair, is deficient. These are the ones where these microsatellite give more and more tumor mutations. And as more and more tumor mutations accumulate, these are like neoantigens, and they recruit more and more T cells to fight with. And these are the cells, herein we realize that these are the cells which have T cell rich environment where we can attack by unlocking these T cells and attack the tumor cells. So MSI and MMR status are highly predictive of immunotherapy, as you have just understood. But the only thing is, it is only seen in about 3.5 to 5% of colorectal cancer. It's a small group, but the therapy is very promising. And we also know that these are the cases which are very, very aggressive, and we have failed in other ways of treating it. So immunotherapy becomes very promising for this small subset of patients. These are the clinically used immune checkpoint inhibitors to activate the T cells. We have PD-1 inhibitor like pembrolizumab and nivolumab, PD-L1 inhibitor like ipilimumab, and CTLA4 inhibitor like atezolizumab. And there are many others in the pipeline and getting into the different trials.
We have 5 minutes.
Okay, pembrolizumab was the first immune checkpoint inhibitor, which clearly showed improvement in the 12-month survival, and especially in these MMR deficient colorectal cancer. And it was also a sustained duration of response. Then it was compared with chemotherapy. In that also, it clearly showed double the, compared to chemo, pembrolizumab clearly increased the survival rates. So, and in Keynote 177 trial, sorry, I think I've repeated, yeah. So, sorry, I'm going back. I'm so sorry. Yeah. And when compared to chemotherapy, these immunotherapies do not have that kind of side effects and very well tolerated. And nowadays, dual immunotherapy with nivolumab, ipilimumab has also shown better survival rates. response rates, and survival rates. And now there is Atomic trial, which is trying to combine atezolizumab along with chemotherapy, like FOLFOX6. And these are the future of our combination therapies with chemoimmunotherapy. And many ongoing trials are there, just showing that how important it is to attack this area. And nowadays we have consensus molecular subtypes of colorectal cancers, wherein we have hot tumors which have a lot of these immune mechanisms going on, like tumor infiltrating lymphocytes, and these are the ones which will respond to immunotherapy, versus the cold tumors which are poor immunogenetically, and then we cannot apply. They are also different in their clinical features. The ones which are immunogenic are poor responders compared to the other types. So clearly MSI and BRAF are associated with survival. These are the two main markers which one must test to know which cases are going to behave badly and which we can use for special target therapies or immunotherapies. And tumor mutation burden is also another way of checking for immune therapies. So this is the number of inhibitors, EGFR, VEGF, immune checkpoint inhibitors, BRAF inhibitors, which are continuously increasing in numbers in their use in clinical. So this is just to show when we have initial therapy in colorectal cancers, first and foremost, the RAS wild type will go for anti-EGFR therapy. But if it is mutated and if it is deficient MMR, we can go for immunotherapy. And if proficient, then we can go for bevacizumab. Once the cancer, in subsequent therapy, when cancer metastasizes or relapses, then we can again check for BRAF and HER2 amplification and apply the inhibitors accordingly. And again, if they are metastasizing, then we again check for the MMR status. If it is deficient, go for immunotherapy. If it is proficient, go for anti-VEGF therapy. And when all are failing, then we go for best supportive care. So this is a continuum of care, and wherein we have to test RAS, BRAF, HER2, MSI, or DMMR, which will guide us throughout the care of the patient. We know who's going to metastasize and relapse in the future. Radiotherapy now can be, whether it can be combined, immunotherapy can be combined to radiotherapy is a new arena. As we can see, radiotherapy induces a lot of immune changes like increased antigen, tumor neoantigens, upregulation of PD-L1, and upregulation of immunomodulatory cell surface molecules. These all make a very good potential of using immunotherapy along with radiotherapy. This is the future, I would say. Thank you.
Thank you, Dr. Anjana, for this nice presentation and briefing us on the genetic level of treatment of rectal cancers. Now I would like to invite Dr. Ashwin D'Souza. He's a consultant colorectal surgeon at Tata Memorial Hospital, and he's going to discuss something beyond TME. We all know the role of TME, but he would like to take us beyond that and see the role of it in rectal cancer surgery. Over to you, Ashwin.
Okay, you see my slides?
Yes, very well.
Okay, let me just go to the slideshow. Yeah. So first of all, let me thank Dr. Hari Bhakti and the organizers for this invitation. And Dr. Paresh Jain has given me the task to deal with TME, but not the standard TME. He has spoken about that TME, transanal, extended, and beyond. The first question is why transanal? So if we look at this low rectal cancer here, and if we look at the specimen that is resected for a tumor that is so low, that is about 4 or 5 centimeters from the anal verge, if we do this procedure laparoscopically, that is the view we are going to see. And as we go nearer and nearer the pelvic floor, the space becomes less and less. The camera, there's a lot of smoke, the camera starts fogging, and we have problems with retraction. After about an hour struggling in the low pelvis, the surgeon starts getting angry, and the anesthetist, the assistant doesn't have a clue of what's happening. And therefore, it led to some thought process of why don't we approach this from a different way. The standard approach is taking the long way from the abdomen, reaching down to the low pelvis where all the work has to be done. Thinking in a reverse fashion, why not approach it transanal where the access is much smaller? And that led to the concept of a transanal TME. So that is the first topic that I would like to touch on. The second issue is that of extended and beyond TME. Now, if we have a tumor that has already transgressed the margins of a total mesorectal excision, our surgical template, clearly we have to think beyond it. And we see that in two surgical situations, one in that of locally advanced tumors and recurrent rectal cancers. And that's where I'll talk about extended and beyond TME. Talking about transanal TME, I think I have to start with a disclaimer. And that is, I have just assisted a single case. We don't routinely perform, we have not performed at all transanal TME at Tata Hospital. But I did have the opportunity to assist a master in this procedure. We had Professor Takimasa come down for our oncosurge in 2019, and there I assisted him firsthand for this procedure. And essentially, it involves first placing a Lone Star retractor. These are only for the very low rectal cancers. And we mark the distal margin under direct vision. The second important step is to achieve an airtight closure of the rectal tube with a purse string, and this is very important to decrease local recurrence. Then some amount of intersphincteric dissection is performed, and this is required to extend beyond the sphincter complex so that we get purchase for the transanal TME platform, which you use. The most commonly used one is the gel point, which is placed through the anus, and we then create a pneumorectum and start performing dissection in a reverse manner, caudally to cranially. So the dissection, this is Professor Takimasa's technique, and he begins laterally first because the plane is easy to develop off the levator, unlike a standard TME where we go posteriorly first. And then once the two lateral planes are developed, they're connected in the posterior plane. We generally go for the posterior second after the lateral is developed, because to avoid entering the presacral space if we go directly into the posterior plane first. And lastly, we go anteriorly to dissect it off the prostate and stop until you reach the seminal vesicles. This is always a two-approach procedure, and then we switch to the abdominal approach and meet the perineal dissection. So in a sense, this is the technology, this is the technique for approaching a transanal TME. Does this really work? So the initial interest actually came from the Bordeaux randomized trial from Quentin Dinos group in France. And he showed a decrease in the CRM positivity when doing a perineal approach. Now, the approach that was used in this paper was a conventional transanal open technique. It was not with the pneumorectum. But with the drastic decrease in CRM positivity, definitely there was a lot of interest in approaching the rectum in this reverse manner. Later on, a couple of years later, he even went on to show that probably we can have better functional outcomes doing a transanal approach for low rectal cancer. And a couple of years later, he came out with long-term results of the Bordeaux randomized trial, showing no real difference in local recurrence or 5-year disease-free survival. But along the way with this technique, we also had some unique problems that were reported in literature. And the first is the higher incidence of urethral injury and other urological injuries. And this paper came out just this year. This is from an international TATME registry, and showed that injuries resulted in a 22% conversion rate, 8% rate of unplanned APR, 9% had a failed urethral repair, and 18% reported persistent urinary dysfunction following a successful repair. So this is a group of complications that are unique to transanal TME, but that's not all. The second issues that started being reported in literature was that of carbon dioxide embolism. And this was never before seen really with any laparoscopic approach. And this mainly arises due to hemorrhage from the periprostatic veins if the plane is lost. And the pneumorectum that is used, which can extend from 12 to 20 millimeters of mercury, that causes this carbon dioxide embolism. It is not fatal, but definitely it causes some hemodynamic problems, although majority of them are able to be completed laparoscopically. Then going further down the line, there were furthermore problems as more and more data came regarding transanal TME. And then this paper came out last year in BJS, where transanal TME was suspended in Norway because they saw a peculiar type of recurrence, which was multifocal and extensive. So this was again unique to a transanal TME approach. And they saw also a higher rate of local recurrence as compared to the national average from the national registry, which was 11.6% as compared to 2.4, and also a higher anastomotic lead rate, which was 8.4 compared to 4.5. So they have temporarily stopped transanal TME in Norway. In the UK also, the ACP-GBI recommended a pause to reflect on the actual use of this technique. And this led to a consensus statement from 14 international surgical societies. They got together and they have put an excellent document together showing guidelines of how one should consider and start adopting this procedure. So that in short is TATME, relatively new approach to the rectum. Is it an approach to be condemned? And so I don't feel so. There was a similar apprehension to laparoscopy in colorectal surgery when it was first introduced with the concern of port site metastasis, but today nobody really mentions about that at all. So it is a technique that is early in its years, and I think it definitely requires technical refinement. There is an ongoing randomized trial, the COLOR3 trial, which has changed some of its protocols based on the literature that has come up. Does it have advantage over lap TME? The advantages that have been mentioned are for male patients, the obese patients, and the low rectum. But in my opinion, if we have a single of these adverse factors, I think lap or robotic is still okay. It is when we have the combination of all these three together, that is when the abdominal minimally invasive is going to be a little difficult. And then maybe that is the patients where the transanal TME has a value. In our Indian population, we have to put it in our perspective. We don't really see obese patients to that extent. And we also have to consider robotic assistance when available does also facilitate access to the low pelvis. So definitely, if one wants to adopt transanal TME, we should look at the guidelines for safe development of technical skills for this procedure, because a learning curve is no longer an acceptable justification for poor oncological outcomes. So let's shift gear. We have a short time to finish the second topic, and that is on extended or beyond TME. And we see this in two settings. One is locally advanced and recurrent rectal cancer. Extended and beyond TME are defined as if we extend the TME resection to include partial or resection of adjacent involved organs, then that would be an extended TME. If we have a formal exenterative procedure, that would be a beyond TME approach. And as I mentioned it, we see it for, we need to adopt an extended TME approach or beyond TME approach for T4B cancers at diagnosis, which we see in 5 to 10% of patients. And also in the setting of recurrent disease, where 6 to 13% of cancers have isolated pelvic recurrence and are amenable to surgical resection. There are various systems to classify recurrent rectal cancers, and I think the most useful from a surgical standpoint is the MSKCC classification, which groups it into quadrants depending on the quadrant of recurrence. And the reason for this is based on the quadrant, we have various surgical options. For posterior disease, we have sacrectomy options. I shall go a little into detail on that. For lateral disease, it's the extralevator APR for the very low down tumors and various extents of extended lateral pelvic sidewall excision. And for anterior disease, we have exenterative procedures which can even involve the pubic bone. Posterior disease, this is an example of a patient of ours. This is a primary rectal cancer, and we can see in the axial view the tumor going into the upper part of into the lower sacrum there, involving the S5. In such situations, these are pretty straightforward. Here we did an S4 sacrectomy. A low sacrectomy is a pretty straightforward operation and can be done without changing the patient's position to prone as well. For higher disease like this patient, this is the setting of a recurrent rectal cancer. We see clear destruction of the S3 vertebra going on to the lower border of S2. We had to get a margin at the S1, S2 disc. Or perform a high sacrectomy, which is defined as at or above the S2-3 disc. When we do a high sacrectomy, it is important to localize the sacral nerves, because as far as possible, we should try to protect the S1 and L4, L5. So that is the S2 there, and the S1 and L4, L5 trunks have already moving towards the sciatic notch. So by preserving the S1, we definitely decrease morbidity. Other less extensive options for sacrectomy are the subcortical sacrectomy. These are for the high rectosigmoid tumors that just invade the superficial sacral cortex. But if we shave it off the bone there, we are probably going to get a positive resection margin. So for a disease that is well medialized, medial to the sacral foramina with less than 10 millimeters of bone invasion, we can go for an anterior cortical sacrectomy. We have done a couple of these. Little more extensive disease is the partial anterior sacrectomy, where the anterior elements are removed and preserving the posterior spinal elements and the sacral nerve roots. Also described is a segmental sacral disconnection, which involves only the hemisacrum and one-sided nerve roots. Here, the sciatic nerve on one side has to be sacrificed, whereas the other side is definitely preserved. Michael Solomon's group from Australia has probably the largest experience with sacrectomy along with pelvic exentration, and he reported on about 100 pelvic exenterations with sacrectomy, majority for rectal cancer, both in the primary and recurrent setting. And if we look at the paper, we see that there were a few high sacrectomies. An R0 resection was achieved in about 72% of patients. These are lengthy operations, about 11-12 hours with significant blood loss. They are complicated procedures. Overall complication rate is 74%, although no mortality at high volume centers, and median hospital stay of 25 days. High versus low sacrectomy, apart from the increasing operating time of blood loss and neurological deficit, mortality, morbidity is the same. But for a patient who has isolated the sacral involvement, I think this is the only curative option that can be offered. Overall survival achieves 38%, 5 years disease survival about the same. Factors negatively influencing survival are the involved margins, the most important probably, lymph node involvement and anterior organ invasion. High sacrectomy per se, apart from the increased neurological deficit, does not really influence the R0 resection rate or survival, of course, at high volume centers. The lateral compartment of extended TME is probably the most difficult, and this is because of the iliac vessels on the pelvic sidewall, which can lead to significant hemorrhage, especially the internal iliac vein, and also the nerves which exit the lumbosacral trunk and the sacral plexus branches, which can lead to neurological dysfunction. The lateral compartment usually has to be addressed in patients with recurrent disease and redo surgery, and tissues are really damaged and planes are really indistinct in this quadrant. But an approach to the lateral compartment is basically by defining the plane of resection. That is our standard mesorectal plane. Disease transgresses that, we adopt a vascular plane. Even further than that, a muscular plane, taking out the obturator internus, and finally is the bony plane. So that in concept is the approach to the extended lateral pelvic sidewall excision. Example of few cases that we have done. Tumor post-chemoradiation infiltrating the medial aspect of the right piriformis. Our resection template here planned on the MRI was to include the internal iliac vein and take the upper digitation of the piriformis muscle along with the tumor. So that is the intra-op photograph, that is the obturator nerve. the external iliac vessels, the ligated internal iliac artery, the distal end of the internal iliac vessels, the sciatic nerve roots there reaching leaving the sciatic foramen, sacrotuberous ligament, and that is the piriformis, what is left of it. The lower part was resected en masse, and we were able to get an R0 resection in this patient. Once again, Michael Solomon has reported on his experience on lateral pelvic compartment excision during pelvic exentration. Over 20 years, 398 pelvic exenterations in this study, and majority for recurrent rectal cancers. That is where we see mainly involvement of the lateral compartments. They do sciatic nerve resections. We don't routinely do that at TMH, but they have done it in 13.5% of patients. Again, these are major operations, 82% overall complications, but R0 impressive to be achieved in nearly 70% of patients. And also their R0 resection rate improved from 21 to 66 over 20 years. And this was mainly done by adopting an access to the lateral compartment through a virgin plane. So one of the 4 planes that I mentioned at the beginning of this section. Moving on to anterior disease, surgical options are pelvic exenterative procedures. The anterior exentration and posterior exentration described in the female, depending on the posterior exentration for the rectum, the anterior exentration mainly for bladder and cervical tumors. Supralevator exentration involves evisceration of all pelvic organs, but preserving the sphincter complex. And of course, the total pelvic exentration. How much time do I have left?
So 2 more minutes.
Oh, okay. Let me just hurry through this then.
Oh.
Just going through the outcomes of pelvic exenteration. I just want to briefly look at the results from the Pelvex collaborative group, which is data from 27 institutions. The important part here is looking at results in the primary and recurrent setting. Complications, everything are same. What main point I want to highlight here is the extent of R0 resections, which is nearly 80% in a primary setting, whereas falls down to 55% in a recurrent setting. So if we have the possibility of getting an R0 resection with an exenterative procedure, we should go for it, because it is the R0 resection only that makes this procedure worthwhile. Let's move on to our own experience at Tata. We have done about 118 extended TME. This is of last year, involving anterior, posterior, lateral quadrants, more than 2 or sometimes 3 quadrants as well. Our experience with exenterations is nearly about 300 right now. This was March last year. We have younger patients. We're lucky to have thinner patients, offering laparoscopy in about 18 to 20% of patients, and en masse sacrectomy in about 12 patients in this series. We choose fit patients, of course, the ASA 1 and 2, complication rate about 52%, comparing well with the Pelvex data. We are able to achieve R0 resection in 90% of our patients, and that is because of very good patient selection, and we are determining our long-term outcomes. Is it really worth it doing such extensive surgery? So if you look at quality of life following pelvic exentration, we see that the quality of life does return to baseline after 6 to 9 months. And if we compare quality of life of pelvic exentration versus abdominoperineal resection, by the 4th or 5th month of surgery, it is about the same. So to conclude, surgical approach for extended or beyond TME depends on the quadrant that is involved. These are high morbidity but low mortality procedures at high volume centers. Should be attended only if we can get an R0 resection. Quality of life, it is worth it. It does return to baseline and is comparable to APR. Thank you.
It was a nice presentation, Ashwin.
Thank you.
Very well kind of concise into the whole gamut, TME and beyond. So moving from a radical surgery to no surgery, we have our next speaker, Professor Reena Engineer from Tata Memorial Hospital. She's been there as a consultant radiation oncologist, and she's going to tell us regarding the non-operative management of rectal cancer. Over to you, Dr. Reena Engineer.
Hello, everybody. Good evening, and I think it's my last talk, and I'm really excited to give this talk, and I'm so thankful to Dr. Haribhakti and Dr. Prasad Dandekar for giving me this opportunity. And this is a slightly controversial topic, but it's really close to my heart. Everybody knows that, and it's a very promising approach. And I hope I do justice in this in this short time. It's not going down. Okay, so as we all know that surgery for rectal cancer, it is the standard, but most of the time when it's for low rectal cancers, there's something called LARS, low anterior resection syndrome, there's fecal leakage, there is urinary continence, there's poor quality of life, especially for very low-lying rectal cancers, and especially when they undergo sphincter-saving surgeries. And coming on to the organ preservation approach, actually this is not a new concept, and it was published way back in 1990, where it was shown that high dose radiation can give rise to complete responses and non-operative management for some select group of patients. But this approach only came into vogue by Dr. Habergamma, where she gave chemoradiation, and she observed that some at least 20% to 25% of patients who have complete clinical radiological response may not need surgery. And she first published it into 2004. Then into 2011, and she's an iconic figure where non-operative management for rectal cancers is any surgeons who have logged in. She's a surgeon from Brazil, and who actually propagated this approach, being a colorectal surgeon herself. And the rest is all history now. And there have been multiple studies now. Most of them are retrospective or small in nature, which are published, and there are many ongoing now, which I'll be discussing, where they have studied this approach of non-operative management for rectal cancers. There have been many meta-analysis and systematic reviews by Samir et al., and which is all there in the literature. I'm not going into detail, but the pool regrowth rate, we don't use the word recurrence for this patients who are on watch and wait policy and develop regrowth. So we call it regrowth because most of them are salvageable, and they are salvageable to the tune of more than 90% in all the series. And the colostomy rate, again, for the salvage group is also 50% only. And overall survival is as good as any good series for when patients have pathological complete response and disease-free survival. So it's all comparable. And this systematic review by Dosa et al. Again showed that local regrowth rate was around 15%. And there was no difference between the patients who underwent surgery or who were kept on watch and wait surgery. These are the changing concepts between survival versus function. We have to adapt according to the response. Surgery and radiation are not antagonistic, but they are complementary. And we have to take our time to decide which are the patients which are optimal for this kind of approach. And there's always a question in surgeon's mind that is the tumor completely gone? And we see that with the MRI and good imaging, there's a definite rectal protocol which we all need to know, even as oncologists who are not the radiologists, but we see that a good MRI with a DWI, diffusion weighted images, it increases the sensitivity from 38 to 77%. And it's also a learning curve for the radiologists. Where when they sit in the MD, it is a complete response or a near complete response. So a typical patient is evaluated by endoscopy, that is sigmoidoscopy, MRI, DWI, and analysis of organ preservation. If there are small tumors, T2, T3A, non-circumferential, near the anal verge, less than 7 centimeter in size, the chances of these kind of tumors, the organ preservation may shoot up to more than 60%. But when there are large tumors, the CRM positive, the organ preservation is mostly accidental, and it can be only into maximum 10 to 15% or 25% of the patients. So we know that the smaller tumor, the earlier tumor, they stand a good chance for this approach. And when we assess the response, we have to add more and more imaging, like even the addition of PET scan or DWI or endorectal ultrasound may increase the probability for predicting complete response. So therefore, when in doubt, we must use all other modalities besides MRI to assess complete response. And what is the optimal interval for assessing response, 6 or 12 weeks? So this study where they saw that when do all the PCRs develop? So they developed, the maximum PCRs occurred around 14 weeks. There were more PCRs, but less in quantity, where they continued to be assessed after 14 weeks. And they also assessed that did they do any injustice by doing surgery beyond 12 weeks. So they saw that they grouped these patients into surgery done between 5 to 6 weeks, 7 to 8, 9 to 10, and 11 to 12, and 13 to 14. And they saw that there was the time to surgery versus survival, there was no difference. So therefore, even operating them late beyond 12 weeks is like we are not hampering their survival. This is some kind of evidence. And how do we know that if there's tumor left? So we have to do diligent follow-up. I'll be discussing the follow-up schedule, because detecting these local regrowths early is paramount to this approach. Because if we lose this chance of detecting it early, it can be the regrowth can become unresectable. It may require more extensive surgery, or it may cause more metastatic disease. So therefore, these are the studies where we see that the regrowth mainly occurs is endoluminal. So 80 to 90% of the cases, it can be detected endoluminal. Therefore, endoscopy or sigmoidoscopy is very important. Then other 5 to 10% occur in bowel wall. Therefore, MRI is very important. And also there could be nodal regrowths as well. There could be complete response in the endoluminal part, but there could be nodes which start regrowing. So therefore, MRI, a good MRI is very, very important for this approach. But besides so many publications and this approach taking more and more takers, there are lots of missing links. Like there's a lack of standardization of when to actually assess call it a complete response. What should be the follow-up schedules? What should be the quality of life assessments scales for this patient, or prompts or patient-reported outcomes. So recently published this month there is an international consensus recommendations on key outcome measures for organ preservation after chemoradiotherapy. So what they did is more than 20 or 25 experts from all over the world were called, and they went through some 396 manuscripts, published studies. And they had consensus and they published their consensus, which we should go through this in this article. Then the organ preservation, the definition is the rectum should be intact and no TME should be performed. There should be no local regional regrowth. That's amenable for limited R0 salvage. There should be, the surgery should be only local excision and no permanent stoma. So these are the definitions when we call it this organ preservation or rectum is preserved. Now about calling a clinical complete response, that is CCR, NCR, near complete response or poor response. So again, there is there are a lot of definitions in literature, but clinical complete response, there should be no tumor palpable on the DRE. There should be no tumor seen, or there should be substantial downstaging of the tumor, and there should be no tumor seen on MRI or sigmoidoscopy. There should be no ulcer or scar. So this is called a clinical complete response. Near complete response is presence of small irregularities, small residual ulcer less than 2 centimeter, or mucosal thickening. Or MRI, there should be obvious significant downstaging, but there could be residual fibrosis or heterogeneous or irregular aspects of signal or regression of lymph nodes with no malignant enhancement more than 5 millimeter in size. So these are called the NCR, and the patients who do not fit into CCR or NCR category are deemed as partial response or poor response. And these are the patients who should not be kept for this approach, and they should be proceeded with the TME or whatever surgery is required. Now, coming to the regrowth, we, as I said, that we don't use the word recurrence for these, and this is a loco-regional regrowth, also includes regrowth in the pelvic organs or the mesorectum, whereas the local regrowth is only confined to the bowel wall, which occurs after the initial CCR or patients who are kept on this wait and watch strategy. What are the time points to determine this complete clinical response? And the evidence of, I would say, to say that, yes, this is the optimal time is still emerging, and there is no hard and fast data to say that these are the timelines which we should. But these responses, they are mainly they can be influenced by the initial tumor stage, biology, the duration and treatment intensity of the treatment, the time of completion of treatment, the methodology to assess the response. And as we see, these are the various studies enlisted. You don't have to go through them. But yes, I just want to highlight this. The assessment of response was different in most of the studies, ranging from 9 weeks to 38 weeks. So still, there is no consensus when to assess the complete response. But most of the responses, they are assessed as 10 and 12 weeks. And role of biopsy treating rectal cancers, that biopsy is contraindicated in this approaches unless there's some specific indication, because the positive biopsy value and positive biopsy may also mean that the tumor does not have the propensity to grow. So biopsy, it can also cause ulceration in the already irradiated rectal mucosa. And the negative biopsy also has no meaning, because it may be just misleading, or it may not be taken from a representative area. So therefore, if there is a suspicion of regrowth, then these patients should straight away go for surgery. This is a follow-up schedule which has come with that consensus guideline. So for first 2 years, the follow-up is usually of 3 to 4 months, consisting of DRE, endoscopy, and pelvic MRI. And chest and abdominal CT can be done either at 6 months or 12 months. But beyond 2 years, then the follow-up increases to 6 months, and the chest and abdomen should be done only annually. So this is more and more standard in most of the studies. And so what should be, now we have so many, like how we had initial talk that short course RT is given, long course RT is given, TNT is given, sometimes brachytherapy is given. So when should be assessing these different approaches? So in this consensus guideline, again, they said that after short course RT or long course RT, the first assessment should be at 12 weeks from the start of treatment, then at 16 to 20 weeks. Then if this long course chemoradiotherapy is followed by brachytherapy, then the assessment should be done at 14 weeks from the start of treatment. Then if the TNT approach is given where chemotherapy is also added, then the response assessment should be done at 24 weeks. And if it is complete total neoadjuvant treatment by prolonged consolidation chemotherapy, then it should be assessed at 34 to 30 weeks after the start of treatment. And now more studies are happening. How do we increase this complete clinical response? And one strategy is to wait beyond 8 weeks. This is chemotherapy given before radiation. Then RT dose escalation by giving a boost to as a EBRT boost, brachytherapy boost. Brachytherapy boost can again be with the contact X-rays or HDR brachytherapy. So all this intensifying the local treatment is aiming at how to reduce the tumor regrowth rate. And these are some of the ways which we can, and the studies are happening. This is in the published literature where HDR brachytherapy regrowth rate was 26%. But Dr. Mint et al., they have published with contact X-ray, the regrowth rate has gone down to 11%. And this year, again, there is a publication where their local regrowth with contact X-ray has gone down to 8%. So more and more research is happening. This is the OPERA trial where they're comparing the EBRT boost versus the contact X-ray boost. And we at Tata, we do endorectal brachytherapy boost. We don't have contact X-rays, but we do MR-guided brachytherapy, 4 gray into now 3 fractions if there is still a residual tumor. And we assess them at 6 weeks post-brachytherapy, then another 6 weeks MRI is done to declare it a complete response. This is a typical response where we see the exudate where we have given the brachytherapy and it clears off in by another 2 or 3 months. So in this approach, surgical removal versus radical CTRT, we are not at loggerheads with surgeons, but yes, we are working together for the benefit of the patients. And mind you, this is only 15 to 20% of all the rectal cancers who present to us. So surgeons need not be threatened that, yes, their cutting will go away. And we at Tata, we started this wait and watch approach in 2000, somewhere late 2013. And this is our first publication in IJSO, where we have shown that, yes, the tumors, there are almost 25% of tumors, they continue to regress beyond 12 weeks also. So there is no need to hurry and, operate on them, because if they are regressing, we continue to put them in watch and wait unless there's a clear-cut regrowth. And our first 36 patients, now we have more than 100 patients on this approach, but in this publication, so the local regrowth was only seen in 17% of the cases. And out of these 6 patients, 4 of them opted for surgery, 2 refused, and they are still alive with the disease. The colostomy rate was only 25% for the salvage group. So ISR could be achieved in these 3 out of 4 patients. And distant metastasis rate was 8%, and overall survival is 96%. Only 1 patient is lost in this entire series. So it is excellent. The results in this select group of patients. It is very cost effective. At Tata Hospital, it is 6 times lesser than for the general patients and 3 times lesser for the private patients compared to surgery. So it is very cost effective, even if you include the follow-up schedule of MRI, repeated MRI. The quality of assessment and prompts are urgently required. We are assessing them. And especially, we should say that EORTC, all 5 scales should be analyzed: the bowel urgency, fecal incontinence, toilet dependency, impotence. All these are very important factors for patients' quality of life. And I must say that patient should be the standard of us, is a center for all of us. And we are working together as a group, as a MDT or as a disease management group for the betterment of these patients. And when we have this approach, and which is safe and it should be, because soon there will be demand from patients. This is a very nice book written by one of the survivors, Mark Davies from London. He's my friend, and it's an excellent book. It's called Saving My Ass. And it is very important that when we can save their rectums, yes, we should do it if it is safe for them. And there are many unanswered questions that which is the best approach. This is, I have enlisted, if anybody wants to go through this. So this is the unanswered question, which LCRT, role of local QL measures, all these are enlisted, which there's research is happening, and it will continue to happen in the next few years. So in the end, I would say take-home message is it is a very promising approach. It is becoming a norm rather than an exception. Response assessment at 12 weeks should be done. 6 weeks for the patients who achieved CCR or NCR. Then 12 weeks, definitely we should wait for the assessment. Strict follow-up schedule should be followed for diagnosing regrowth, and outcomes are similar for the patients who undergo surgery. So we should not shy away when the patients are compliant. So thank you very much. I would end my talk here.
Thank you, Dr. Engineer, for giving this brief and a detailed insight into the non-operative management of rectal cancer. It is definitely taking up globally. If we see this approach is definitely going up and up over a period of time. I'm sure more of us as surgeons will be looking into the long-term outcomes of this approach. So moving on to our panel discussion, I hand over the mic to Dr. Prasad Dandekar, who's the head of the Department Radiation Oncology at HN Reliance Hospital, and invite all the panelists to join the panel. Over to you, Prasad.
Thank you, Paresh. This has been an amazing CME because we are absolutely spot on time. And at the same time, we have had such amazing talks, very enriching learnings in these last 2 hours.
Can you allow my video to be on? Because
Sure, Reena. I was just wondering whether you want to sort of look at your bandwidth, because in between your voice was dropping. So if that happens, then maybe you could go off video, because that will allow your voice to be heard better. But let's see as we go along.
Okay. Otherwise, you can stop my video.
Yeah, absolutely. So before we begin the panel, I just want to remind people who are attending, please fill up the form which we have posted in the chat box. Unless that form is filled, you will not get the MMC registration points, because that's the attendance form from the MMC. So please do fill up that form. Please post your questions in the Q&A box, where we already have few questions, and we'll straight away jump into the panel discussion. So Dr. Reena, I'm taking cues from Reena's presentation, and she spoke about the role of MRI and developing a good MRI protocol. And on today's panel, we have Dr. Karthik Ganeshan, who's a radiologist par excellence, and we are very fortunate to have him on our team. So Karthik, I wanted to ask you, what sort of protocol would you recommend in rectal cancer MRI? And secondly, there's a lot of variability that we see when we see the MRIs done everywhere. So what sort of is your recommendation on that front?
Hi, thanks, Prasad, for the invitation. Good evening to all the other panelists and the delegates. So that's, if I were to look at it, MR is the current platinum standard of imaging when it comes to assessing rectal cancer. It's not even the gold standard. It's a platinum standard simply because it gives you information which is far beyond the reach of any other imaging or any other kind of modality to get you that kind of information. Now, at the onset, I'll tell you one thing, that when you're imaging the rectum, there are a lot of parameters which need to be looked in, not just the kind of sequences you do. It starts from the scanner itself. So ideally, what you want to be doing this is working on a 3 Tesla scanner, because the amount of resolution and information you get on a 3 Tesla is literally about 1.5 to 2 times more than what you get on a 1.5 scanner. That's the first thing itself. The second thing is the preparation of the bowel. That's very, very important, because when you have superficial lesions, early T1s or probably even sometimes T2 lesions, which are kind of carpeting the surface, infiltrating the rectal wall. If you have any fecal material or any impacted stuff sitting up over there, you can get some artifactual signal changes which can preclude an accurate diagnosis. So bowel preparation is important. The third point is whether you need to use a couple of things. One is an antispasmodic, which you should use because peristaltic movements tend to go down. That kind of helps you a wee bit. Lastly, some people say whether we should use rectal distension. And I'm a person who is against it simply because you tend to miss out flattish lesions, or you tend to miss out early lesions. So I tend to avoid rectal gel administration. So those are the 4 basic things which you should know before going in for the scan itself. If you're looking at the scan, you need a triplanar T2, which is mandatory for assessing the rectal wall, because the T2 gives you the most important information in assessing the muscle. Of course, it is supported by certain sequences where you can assess using the diffusion weighted images. Now, there are a lot of variations in how you use the diffusion. The important thing to remember about diffusion is that the diffusion ADC, where when you're going to assess them, you need to use the same parameters all the time in every patient. If the parameters are going to be variable, then you're not going to be able to standardize and give cutoffs and standard deviations. And because these are all specific, these are all quantitative imaging techniques, not just eyeballing. If you eyeball a diffusion weighted image, you're going to get it wrong more often than just say right. And I'll give you a lot of reasons for that. The last one is whether we give contrast. Now, there are 2 schools of thought with the contrast. The contrast abroad, a lot of people do not use contrast. Some institutions do use contrast because, especially if you're looking for certain phenotypes, like if you look at the signet cell type of a mucinous or of a mucinous tumor. Now, what happens is a signet cell tumor is a superficial tumor, tends to carpet along the submucosal surface, and a non-contrast sequence may sometimes, not all the time, but may sometimes preclude the accurate estimation of the longitudinal and the radial extent of the disease. So contrast helps in certain indications, not in all of them. But by and large, if I would just put it in one short synopsis, 3 Tesla MR, antispasmodic, no rectal gel, triplanar T2s, which are absolutely gold standard, and a diffusion is where you need to at least, that should be the minimum requirement for an ideal MR. That's absolutely.
Thanks, Karthik.
Yeah.
I want to ask surgeons and radiation oncologists on their interpretation of MRs. I personally very often look at the MRs and it's all Greek and Latin most of the time, unless you have a very good radiologist like we do have. It is really, really very difficult. So what's the experience of other clinicians about reading MRIs on your own?
Yeah, if I may, I just want to add one point is that at Tata, we sometimes see MRIs done outside, and a very common sequence is the fat suppressed sequence. And we get really worried about seeing that because we need to see the fat. So a non-fat suppressed sequence is what we want to look at, because the contrast we don't really go for, but the non-fat suppressed sequences what we really need, because the fat in the rectum serves as a contrast. The fat helps us to define the mesorectal fascia. That is one. And regarding reading MRIs, I think every single of our patients are seen in a joint clinic, and we actually plan our surgery on the MR. So if you've seen in my talk, if you're planning an extended TME resection, we see which quadrant we're going to go beyond the TME plane, which vessel we're going to take, which nerve we're going to save, at what sacral level, the presacral fascia, the veins, every single thing. And sometimes our joint clinics go on till 6 and 7, and that's because we are fighting on the MR. So there's no other word for it. It is the platinum standard.
As a radiation oncologist, I would like to insist that we also like to read and understand our own MRIs. And thanks to our radiologist, Dr. Suprita, who really taught us. And it is required for planning, for contouring. And we also give a lot of SIBs, a simultaneous integrated boost to the nose or wherever we want to give. So it is very important even for the radiation oncologists to learn to read their MRIs and sit with their radiologist during contouring and planning.
If I may add, as Ashwin said, we always plan our surgeries based on the MR. And we, again, fortunately, we have Karthik available at the nth hour. So we sit with him a day prior to read the MR, to plan our surgery, and then we go ahead. Without seeing the MR, it's not really worth attempting at least a rectal cancer surgery, because your planes are completely different based on the location of the tumor. So we try our best to read the MR, but if in doubt, we kind of bother Karthik at 12 in the night.
So while we are on the topic of imaging, Dr. Vimal Jain has asked a question. What's the role of PET scan? Nobody here has spoken about PET scan, which is very, very different from what we hear in all other oncological conferences. The PET scan is like all over the place. So what's the view of the panel? Karthik, do you want to go first?
Yeah, I don't mind. I don't find a role for PET for local staging of rectal cancer. It's pretty limited. I would use it sparingly. MR, by and large, tells you everything, unless you've got disease which is above the peritoneal reflection, or you've got inframesocholic or mental disease. That's when probably, but I don't think even an MR, even if you, at many of our cases, we actually end up doing an MR liver more often than actually a CT, because the MR liver gives you so much of information in terms of anatomical co-localization of the disease. And then surgeons are moving on also with that in different ways of managing them. So you could have a two-step approach where you first tackle the liver, and then you go in, and when you've downstage it, you go and take out the rectal cancer itself. So MR allows you also, and also because of the way surgeons are looking at it, a lot of non-anatomic resections are happening, not just pure segmental resections or lobectomies, but a lot of non-anatomical resections are occurring. So by and large, I would say PET does not have much of a role in the initial part of it. But yes, post-surgery, when you're following them up, like a post-APR, and you're looking for disease, usually a CT would do, a CT chest, abdomen, pelvis. But there are some extraneous circumstances where you want to do PET. But very important to remember is that two locations PET does not perform so well. One is the liver and the other is the bone. I would rather use MR in both those with specific indications. Otherwise, a CT would take care of it.
I want to ask Karthik one question, Prasad. Karthik, you often talk about texture. Yeah. And I wanted to know whether you would have anything to say about the role of texture in, especially I think Dr. Reena Engineer's talk was very, very provocative. And I think I want to know whether texture is going to have any role to play in looking at minimal disease. That's because that's something you often speak about. I just want to know.
I can share my slide. I've kept it hidden, in case I get more time. So this was a thesis done by one of my students. So I'll show it to you. So this is what he had. Just give me a second. So we did this study of texture analysis in in predicting as a biomarker for tumor response. And we did it on around 100 patients, pre-radiation MRIs and post-radiation MRIs. And we use this to evaluate response prediction. And was a summary of results that it was the most significant predictor to differentiate complete clinical response versus partial response, and it was the most significant predictor to differentiate no response or partial response or pathological complete response. So we also looked into the patients who underwent. So we blinded the radiologists who were doing, the contouring, and we saw that yes, in addition to what the radiologist, the human eye can perceive, texture analysis, we have this TexRat software, can add into this to predict the response in the pre-treatment MRI as well as predict the response in the post-treatment MRI. So it is a very promising tool, and we plan to take it further, and a very good experience for us. Thank you.
If I may add something, so that was a great question. But what we are doing, we have used it for now last about 4.5 to 5 years, and I think the total number is about 125 odd patients where we have got pre as well as post treatment with MR and then serial follow up. We have done it actually in 2 different ways. We have our own MR tumor regression scoring. So Paresh and Prasad will say that you'll see that in the post-treatment, we write an MR-TRG score. But over and above the MR-TRG, we add the texture in terms of the research part of it. And we published our data actually at the ISMRM Society meeting, which is very well received, where we were really able to predict. The bigger thing was the complete responders. And we had nearly about 96% of our MR-TRG scores matched with the texture and the histopathology. It was that high was the level of specificity of which first order texture kinetics. Now there are numerous texture kinetics. These are not visible. These are quantitative analysis measures. And we could use something like entropy, MPPs, which is just basically the mean pixel value, skewness, kurtosis, and we got some amazing results. And this is the way forward, because qualitative imaging has got its limitations because it's very subjective. But quantitative imaging is based on repeatability and reproducibility. Now that's where it's going to head, because tomorrow, where we also did a lot of work was whether we could differentiate mucin from non-mucin producing tumors. And we were able to do that as well and predict. And by and large, most mucin producing tumors don't respond well to long course chemo. They are very poor. So they're usually TRG3s, which are less than 50% response, unequivocal findings, or they're going to be poor responders or progressors on treatment. That includes the signet cell as well. We could differentiate the non-mucin from the mucin, and we could differentiate the signet as well. So that is where we went one step ahead, and we were able to get histological correlation with all of these pathologies. So I think that's the way forward. Quantitative imaging is going to be taking this to a whole new level. And I think that's a great question. That's a great question.
So that's really great. And with a new MRI coming up at our place, I think we will only take it to another level, Karthik. Thanks.
Yeah.
Moving on to radiotherapy, Dr. Naseem, I heard you say that the short course versus the long course CTRT almost has equivalent results. So how do we really sort of decide as to which patient should go for short course versus long course in clinical situations?
Hi. So as Dr. Karthik rightly said, the MRI plays a very important role in staging the patient. So in short course radiation therapy, the patient should be appropriately selected. So the patient, the tumor T2, T3 tumors who are in the mid-rectum, in those cases, the short course works very well. Also in upper rectum where the downstaging is not required. And also in those cases wherein patient is fragile, not able to take long course chemo RT. So in those cases also, but the only thing is that the CRM should be more than 2 millimeters. So in that manner, the MRI is really helpful in identifying the correct patient.
So I wanted to check with Reena and Ashwin. We don't have at our institute very large experience in using short course radiation. What has been your experience with short course radiotherapy and surgery after that?
Ashwin, you can answer.
Yeah, sure. So I just want to add one more indication to that. One would be that if you're treating a patient with METs in the curative setting, that is where we would give short course radiation with chemotherapy and then reassess for either a synchronous or a stage resection. So surgically, if you ask my opinion, operating after short course versus long course, I think it is a little more difficult to operate after short course because you get a lot more edema, there is a lot more fibrosis, and if you have short course and delayed surgery, the planes, especially if you're doing intersphincteric resection and working between the sphincters, that plane really gets obscured. And I know the oncological results are almost equivalent between the same, but I think the local control is probably, and the local downstaging is probably better for the long course regimen. If you look at the Rapido trial as well, there is a difference in the local control, even though they have short course versus the long course there. It was not reaching significance, it was P 0.09, but they had only 22% patients low rectal cancers, the rest were mid and upper. So if you look at long course versus short course, if you're looking at downstaging, if you're looking at sphincter preservation, the borderline cases, the ISR cases, I would go for the long course chemoradiation.
So as such, as per literature or as per evidence, there is no superiority of long course over short course now after this Rapido trial. But yes, because our surgeons are not very comfortable, and in our center, we more of the patients for the very low line, we try to go for watch and wait strategy. If they have a good response, we also add some kind of boost with endorectal. So therefore, these select group of patients, we prefer long course over short course. But there is no, as such, there is no black and white indication for long course over short course.
Just one more point is, if you are thinking of organ preservation, we are going for long course. Although the oncological outcomes are same, I think the biological effect of the radiation is different. So
he thinks, but none of the trials is showing it. Yeah.
I think the biology of radiation, I mean, we've been using radiation for more than 100 years now, and it's still more of a mystery, and we are still learning a lot about radiation, you know. And
you should ask the surgeon that, my friend. It's we who know. It's we who know. Because we operate on so that's why I was listening to Ashwin very carefully, and I would really, I wanted to ask, I mean, if there is more edema, if there is more jumbling up of the planes, in how is it equally good? I don't understand. If clearly there is a disruption of planes and all that, then it is a more difficult patient to work on, I would imagine. So. Yeah.
But none of the randomized trials have shown it, so we can't say for sure, but definitely we can choose our patient because both are equivalent, so then we have the option. Yeah.
That's right. Yeah.
And while we are on radiotherapy, again, we have some data which suggests there's not much of a difference between, say, 3D CRT or conventional radiotherapy compared to Rapidoc and Imrt. I do remember when we started our operations here and we started using Rapidoc for our patients, Paresh and other surgeons telling me that the planes are far better than what they had seen earlier. So I wanted to ask the surgeons and radoncs here, do you have any, you may not have objective evidence, but do you have a subjective feeling that, you know, certain techniques of radiation are much better from the surgical point of view?
Yeah, so surgically, I know for sure that patients radiated at Tata Hospital, we are more comfortable operating. Because we do get patients who get the radiation outside. Some centers are very good. but some centers we really struggle. So definitely the radiation technique and the instrumentation definitely plays a role. That there's no question about that.
I can share my experience. So, like IMRT, I prefer in certain cases. These are very, very soft indications, but yes. So, where the patient, where the tumors are very low lying, it is near the vagina or near the urethra or vulva, it will get more radiation. So, those cases, I definitely, or where there's very long field of radiation, where you have to include from L4 to the anal verge, So all those cases, I definitely prefer IMRT and VMAT over 3D CRT. But if there are small mid-rectal tumor or upper rectal tumor where the portals are not very large and I am very confident of my dose pills, I can treat with 3D CRT. This doesn't make much difference. But especially for low-lying rectal cancers, IMRT does make a difference.
So, if I may just add, as rightly pointed out by Dr. Reena Engineer, for the lower rectal tumors, the type of radiation does really make a difference. We have seen few patients from across the country come across with the standard radiation, and surgery has been really been a nightmare to operate on those cases. Even an electric device like electrocautery doesn't work very well in these cases. So definitely radiation technology does make a difference, and especially for low rectal tumors where you're already struggling for a plane. And in those cases, high-end Rapido and IMRT, I'm sure does make a big difference.
And also for the radiation oncologists who are logged in, it's very important to follow the contouring guidelines and plan your patients very carefully, because when to include the inguinal nodes, when to include the obturator nodes or external eyelid nodes, there are definite indications. And please go through these guidelines, which are published in 2016 by Dr. Valentini's group. So it's a must for the radiation oncologist to have a proper planning and then.
Yeah, and we've recently had the 2021 Astro guidelines also come in, and I think some part of it Dr. Naseem also shared in her presentation. So they're quite very well established, and they've sort of categorized everything really very well. So coming to the question of chemotherapy, and Dr. Anjana and Preetham have really gone into the depths of it, but the question of total neoadjuvant therapy. Everybody, Preetham spoke quite a lot about it, but I don't see anybody practicing it. So what's happening there? Why are we not using it in our clinical practice? Any ideas from Preetham and Anjana?
Yeah, so the data for the total neoadjuvant therapy looks promising. Now, there are two issues. One is the toxicity part. Because we are giving a pre-op CTRT and then the long course, the total neoadjuvant therapy. And the second part is the long-term follow-up data that doesn't exist with us. As we have been very comfortable with pre-op CTRT followed by surgery and the adjoint chemotherapy. So, that is the place where we have been really lacking for. But definitely it is coming in a good way, because, and surely I think we are slowly and steadily we are taking up in our own practice, especially in those patients where after the radiation, still the CRN looks involved, and we fear for the margins. In that situation, we are still, we are taking up this regimen of total neoadjuvant therapy.
Any views from the surgeons?
Yeah, just a few concerns regarding the Rapido trial. I think we have to be a little careful before we generalize its use to all classes, because we see a lot of poorly differentiated cancers, signating mucin secreting cancers, and I don't think these were adequately covered in Rapido. They were just 10%. Low rectal cancers were just 22% in Rapido. And also they had T4, they did include, but they were just 32%. So a large bulk of the tumors that were there in Rapido were the T2, T3 upper mid rectum. So I am a little bit wary about adopting it generally for all patients as a standard of care. I think we still have to choose our patients. There is also a risk of over-treatment in a subgroup of patients if we go for total neoadjuvant therapy. If we have upper mid-rectal cancers, the early T3 and ones who respond very well, we could probably operate them, and we could even avoid adjuvant chemotherapy if they are node negative. There's quite a lot of data to avoid adjuvant therapy in these patients. So they get treated only with two modalities, the radiation and the surgery. So those are the two risks, I think, with total neoadjuvant that we have to be careful about.
Yeah, I mean, we could definitely reduce the treatment that they are receiving. So, Anjana, your presentation, you spoke about a lot of molecules that have come up, and I had two sort of concerns around that. One was, is there any way we can have like a sort of a general assessment, like say using something like Foundation One in our patients routinely, where we can customize the treatment more often? Currently, we are sort of going at a level where you say, okay, let's start Keras radiotherapy, then do surgery, and then, the customization is coming more so in the salvage situation or a metastatic situation. We're still not sort of doing it upfront. So what's stopping us from doing that?
So, of course, we are learning more and more as we are using these target therapies, immunotherapies in variety of cancers. And we are realizing the anatomy is no longer important. It is the molecular biology which drives the cancer cell. So that's why these generalizations are there, or general application. We learn from melanoma, we learn from small cell cancer, and now we apply it in colorectal cancer as we are studying the biology. So once we will be getting better results in metastatic situations, of course, there are already trials in pipeline which are trying to use these agents. If we already know that it is MSI high and deficient MMR kind of a tumor to begin with, if we give neoadjuvant immunotherapy, will it increase the pathological CR? So I'm sure there is learning from metastatic situations and trying to push it towards the earlier, but still it's not yet. But definitely we have learned our lessons that MSI, the MMR status, BRAF mutations, these are the main two things which drive our whole thinking around what should we give initially, what should we give later lines. And these are the ones which we test to begin with in a metastatic situation.
So Anjana, if I may ask you, just as say in a parallel situation like breast cancer, now it's become standard to do receptors and HER2 and the MIB index. So in colorectal, would you say there are 3 or 4 markers which kind of should be done as a baseline? Or would you think that's something only in the metastatic situation, or how would you recommend these?
Well, yes, sir. As per the guidelines, we don't really ask for these markers to early stages below above. I mean, still stage 3, but sometimes we know the markers. We know they're available. We know we can do it, and we really apply them in metastatic situations. So whenever we see a high risk case in stage 3. And sometimes we do not know how the behavior, we can't predict in next 2 years or 5 years what will be the survival and what will be the situation. So sometimes we do ask upfront, but yet they're not recommended. We should not run after those because still standard therapies work best. And always in the stage 2 onwards, wherein there is, we want to know the benefit of chemotherapy, how we know MSI deficient ones are not going to be the ones who respond. So we try to, in early stages, only to decide whether chemo should be beneficial or not beneficial, we can do MSI status. Otherwise, there is no standard that in all colorectal cancers, the moment you diagnose them, you do all the markers. Because they're expensive, each and every one is expensive. And especially some patients, they just go and just do it because it is available. And we have to reverse the whole thing and tell them we don't want to look at that report right now because it is not applicable at that moment since we have standard approaches.
Yeah, that's a challenge that we are facing clinically, that there are so many labs now who are going to patients directly and promoting these things. And then you are in a fix that as a clinician, you have that report and the patient says, I can't afford this. And it's really a sad situation. Sorry,
And
Preetam, you were
sometimes they
saying
can't
something.
afford and we can't interpret because it doesn't make sense in that moment of time.
Yeah. So to add on, as rightly mentioned, for CA colon stage 3 cancers, generally we do a MSI testing. Other testings we are not doing at present in stage 1 to stage 3 colon or colorectal cancers. For stage 4, only there are guidelines to do this test because we can use the directed therapies in these particular situations with stage 4 cancers, but not with the stage 1 to stage 3 cancers of rectal cancers.
I would like to, in continuity ask Dr. Ashwin D'Souza, you in your presentation, you said you had a fairly vast experience with the extended mesorectal excisions, and you had a 90.4% R0 excision rate. So did you use any markers in choosing the patients, Ashwin?
Not really, so they all get the standard chemotherapy and they are all non-metastatic. So I think the markers only help.
Yeah, they have to be
non-metastatic
non-metastatic for those.
So markers for deciding surgery or in that setting, I don't think there is a role as yet. It is the standard chemo and then surgery. But one interesting thing that we did notice when we looked at our own series of extended resections, a large number of these patients often refuse surgery because of the morbidity, the permanent urostomy, the permanent colostomy, and they just go for chemotherapy. Now, when we looked at this subset where they have refused surgery and they have got chemotherapy, we found that in this subset of patients, there was no real advantage of giving the chemo one. And second, it was quite surprising actually to us. We need a larger study to confirm this finding though. And in all these situations, it never really decreased our extent of surgical resection. So the surgical resection, which was initially planned, and then the patient usually came back and we went and operated. So the exentration still remains the exentration. So, by giving chemotherapy, we are not going to come with something less. So those are the two things that we saw.
So may I ask in continuation with that question? Yeah. So once given the radiation and it's still an extended disease, are there then an indication for either TNT or consider for radical resection?
Yeah. So what we do is if we can get an R0 resection with an extended TME or an exentration, I think we would go ahead with surgery.
Okay.
Because I don't think this group was adequately covered in the Rapido trial, and we don't have the evidence to generalize for this group. Usually these patients have the bulky tumors with the entire pelvis is filled with disease, and a lot of them progress on chemo. So you're also dealing with about 10 to 15% will progress on chemotherapy. So resectable disease today with an R0 resection with an extended TME may become unresectable after giving for 3 or 4 cycles of chemo. So if we do have an R0 resection with an extended TME or beyond TME approach, we would offer surgery for this patient.
So while Dr. Karthik mentioned use of MRI for metastatic disease, that's one topic we really couldn't sort of add into the CME program because we're running out of time. But I just wanted comments from the surgeons and medical oncologists about management of oligometastatic disease, specifically liver disease. What sort of protocols do you use, and what's your experience with that?
So for rectum, I think for all patients, colorectal, the first decision that we make is whether this patient is potentially resectable or potentially unresectable. I think that is going to define our intent, whether it is going to be curative or palliative. So as a guiding principle, what we define as potentially resectable is if we can offer some sort of resectional or ablative therapy at every site of metastasis at presentation. So if we may have 4 or 5 liver mets, but all in the right lobe. So that we would label as potentially resectable, and then we define our intent at baseline as curative for this patient. So once we define our intent, that is the first step. Then if it is a rectal cancer, we would go for short course radiation, locally advanced rectum. We would go for short course with chemotherapy and then reassess response both at the primary as well as the site of metastasis. For colon cancer, we would primarily look at the primary to see whether that is symptomatic or not, because majority of these are either bleeding or obstructed. And those are the two prohibitive signs for them, situations for them to receive chemotherapy. So that would be the first thing to decide for colon. So just broad principles that we use in our decision-making process.
So as said, we normally like to look for a metastatic control before we go for the target, because it's the metastatic disease which gonna take the toll rather than the primary. So if we think with the chemotherapy, the metastatic is kind of coming under control after giving at least 3 cycles, we reassess and see the status and then take the next step. Whether that also gives us time to know the biology of the tumor. And that's helped in better delineation of further line of management. So when it comes to metastatic, it's normally we like to take a metastatic control and then look for the primary, if it's targetable or not.
And a quick comment on use of HIPEC in rectal cancers.
So HIPEC, we are very selective. For the very low PCI patients, which PCI less than 10, these are patients which generally have only local peritoneal involvement. We don't do HIPEC for these patients as a rule. We would only resect them and resect the peritoneum in continuity. For the high PCI above 17, definitely HIPEC is not going to help because we can't get CC0 resection in almost all of these patients. For signet ring cancers, we decrease the PCI a little bit because the biology is very aggressive. So if that goes above 12 to 15, then for signet ring, we are also a little bit reluctant to offer CRS HIPEC for those patients because their biology is quite bad. So basically, it is for the 10 to 15 PCI. Less than that, where we offer the CRS and HIPEC for them. Pseudomyxoma, of course, is a different entity. That is totally different. So that is not included here, just to make it clear.
With the recent Colopac trial, it is kind of a trial which says HIPEC doesn't really work that much for a colorectal as compared to the other ovarian and the gastric tumors. So you got to select your case very well. With a low PCI and a non-signet ring, they are the cases where you can offer them a HIPEC. But rest is kind of cytoreductive surgeries on the cards for these peritoneal deposit disease patients.
Okay. We have a few questions from the audience, and one I would like to address to Dr. Reena. Reena, are you around? Yeah, okay. Is there any role of SBRT in recurrent rectal cancers?
And so yes, there is few series available, and we do give in certain situations, SBRT, especially where there is pre-sacral mets but these patients will be going for surgery, for their recurrent tumors. But I would say it's very limited role, but yes, we have tried, and especially lateral pelvic wall recurrences and all, SBRT can be given.
And Reena, while Dr. Haribhakti rightly mentioned that your talk has been very provocative, I wanted to ask you, we have been using IMRT for a while. Is it time for using another type of IMRT, immunoradiotherapy? What are your thoughts about what Anjana mentioned about combining radiotherapy with immunotherapy?
Yes, so combining immunotherapy with radiotherapy, yes, mainly with the short course RT. There's some data coming up, and protons also maybe in the future. So yes, that there will. It is in the future. But immunomarkers, as Anjana said, it's like a very limited role yet in rectal cancers. But yes, if they have, if they're positive, definitely, why not?
And would you use SBRT for say solitary, oligometastatic disease which presents after primary treatment is over, in a patient who cannot withstand a liver resection, or where you cannot achieve it by other means? Is SBRT at
Yes, I would say SBRT is one of the options. Even in the NCCN guidelines, the SBRT of liver is an option, and especially when they are not going for resection. So I would say, and they're very good results, and we give very high doses of radiation to the tune of 15 gray per fraction to 3 fractions. So we are using it.
Dr. Haribhakti has a huge head and neck practice, and one of the paradigm shift in head and neck cancer has been laryngeal preservation. And with chemoradiotherapy, the laryngeal preservation rate is 70% approximately. And I was a bit surprised to see your presentation, Rina, where you said in patients who have clinical CR, the organ preservation rate in rectum is 62%.
Yes. So
that's quite a
there's
shocking
paper
number.
That's what I said.
Yeah, in fact, there's a paper in Lancet Oncology in 2016 by Dr. Anne Appel. She's a physicist who's done this trial, and she gave brachytherapy at the end of EBRT, and her majority of the patients, I think 60 or 70% were T2 tumors, T2N1s. And she showed an organ preservation rate of 72%. So it's slowly moving on towards like squamous carcinoma now, the rectal cancers, the small rectal cancers.
Yeah, I know that was really a huge.
It's a paradigm shift, yeah.
Paradigm shift, absolute paradigm shift, no question about it.
Yeah.
Just one word of caution for wait and watch. The thing is,
you might.
Word of caution is that these are the good responders. And
yes.
they are the patients who
super
are very
selected.
Controllable. They are very controllable and very treatable cancer. So I think it is important to have a very active wait and watch program if any institute wants to undertake this. So it is to the
and
extent
an MDT
and an MDT, absolutely. So we examine each of these patients by 2 clinicians at every single visit. So, and each PR examination is documented. If you feel clinically there is some regrowth, it is every patient gets a sigmoidoscopy with an image that is documented and compared with the next one. The MRI is compared with the previous one. And there is a whole group of people who track these patients. They miss a follow-up. They are brought back to the clinic. So the thing is, these it would be irresponsible to take up.
It is a rigorous program
if you don't have the team for it. Because if you let a patient get a regrowth and then land up with an exenteration,
it's a disaster.
That would be, I think, unfair.
Yeah, I mean, the role of a good radiologist who is going to follow these patients up regularly and a good, GI specialist with endoscopies is absolutely vital. So as we're coming close to the end of the panel, I'm looking at there are a few questions coming up in the panel also. I want to invite each of the panelists to sort of share their comments and, sort of a take-home message for everyone, starting from Dr. Karthik. What's your take-home message for people who are attending today?
Thanks, Prasad. Probably, let's keep it simple. MR before and MR after treatment is the way to go forward. This is just prior to surgery is what I'm talking about, because you get very key clinical indicators on whether this is locally aggressive disease. Do you look at the mesorectal and extramesorectal nodal burden? You're a pretty good predictor of extramural venous invasion. You can identify skip deposits or tumor deposits, not only along the vessels, but tracking all the way rostrally up to the inferior mesenteric. That's where the surgeon goes and ligates. It's great for predicting or detecting metastases, both at the level of the osseous as well as the level of the liver. And of course, post-treatment, you can assess it generally 8 to 12 weeks later for the MR tumor regression grading. And that's a pretty good indicator also in terms of how the surgical lines are going to happen. And then when you're following it up, probably do a chest CT along with an abdomen pelvis. But if push comes to shove, a PET CT does play a role in some of these cases, but not in all these patients. And lastly, there is a paradigm shift to move away from qualitative imaging, which is now the current benchmark, to a more rigorous quantitative imaging technique, which is going to be a much better predictor of treatment-related risk. I think that is going to be a very accurate. It's got even a genetic connotation. You can correlate your textures even with genetic changes, mutations, like the Keras mutations, the wild mutations. Those things are still going on textures. So I think it's got a huge role to play in the way you manage rectal cancers.
Anyone else would like to add? Dr. Ashwin, Dr. Anjana, Dr. Paresh, Reena, Naseem?
Yeah, so I'd just like to sum up my section that was handed over to me. Transanal TME has promised a lot of caution, very specialized, should be attempted only by high volume surgeons. And I would like to also make everyone aware that the locally advanced tumors and the recurrent tumors, all is not lost. There are extended TME procedures, there are exenerative procedures that do offer long-term control in 48 to 50% of patients. In that setting, I think that is the only option left for these patients. And they should be referred to centers that do offer these procedures, but these are not a one-man surgeon approach. It is a team. So it requires to be sent to a center that can manage these patients as a team. So that would be my sum up from my section of this CME.
And Dr. Ashwin, I must confess here one thing, that whenever our surgeons would say, oh, this patient needs an exenteration, in my mind is like, oh, that's like a totally gone case. Why, bother? But your talk has really made me aware, and yes. I hope many others, that it's not, all is not lost. And having another name like Beyond TME also helps. Exenteration sounds like really, palliative.
Yes, Prasad. The first case when they did a total sacrectomy, I was shocked. I thought patient won't be able to sit on the. So I was actually Saklani and Ashwin made me see this patient, and patient was sitting and looking normal, and like it was really for paradigm shift for me to see these cases, half the sacrum, half the ilium gone, and all that, still having a normal kind of life. Yeah.
I know I didn't want to go into technicalities, Ashwin, but what did you do? Did you have to do any free tissue transfer to protect the cord, the conus and all that? I don't know how you do it, because I'm sure you would need tissue, to bring in fresh tissue to cover those vital areas, or am I just imagining things?
So the cord is not, you just have to ligate the canal there, that's all.
The lowest portion,
the chorda equina.
Yeah, so we just ligate the canal there. I mean, we take help from our orthopedic surgeons who do a lot of sacrectomy and pelvis. So they are there, the plastics are there, and we are there. So as I said, it's not a one-man surgery. It is a team.
Yes.
So we finish our part, they come in, many times the patient is turned from supine to prone and then back again to supine. It takes time. But if we get R0, it is definitely rewarding.
Of course.
So practically up to S3, you can S5, 4, and 3 you can remove without compromising the spinal canal. And because S1 is required for the pelvic stabilization, and S1 and S2 are the two joints which are required for pelvic stabilization with the ilium. So up to S3 kind of is relatively a stable pelvis without compromising the spinal canal.
Any other comments from the panelists to sum up?
So just a one-liner from my talk, minimal access surgery, it's a minimal access and not a minimal invasive surgery. The extent of invasion is still the same what we were doing 10 years back. It's the access which has changed from open to lap to robotic. But the morbidity and the stuff are relatively still the same. And you got to select your case very well. And not that you know a robotic or a lab, you should offer it to everyone. But yes, majority of the surgeries can be accomplished laparoscopically or robotic. And you have to select your case well so that the outcomes are better. Thank you.
Dr. Preetham?
Yes, sir. So pre-op CDRT, still the gold standard. TNT, new kid on the block. but we need to choose it very carefully for selected patients.
Thank you. So we are at the top of the hour. It's exactly 7 o'clock when we promised we would wind up. So thank you very much, everyone, for joining. I hand over to Dr. Hari Bhakti for concluding the panel.
Yeah, thank you very much, everybody, all the participants. I can still see 69 participants, which is amazing. I have to admit, as a person who hasn't performed colorectal surgery for almost 25 years, I was completely with it, and I think it was a very, very educative, very informative meeting. So I want to start by thanking all the speakers, the home team, and also especially the TMH speakers, Dr. Ashwin D'Souza and Dr. Reena Engineer. I think both of them gave very, very enlightening talks, and their panel participation also gave us a lot of food for thought. So thank you very much to all the participants who made it a very rich scientific experience. We have to thank the behind the scenes people. Dr. Amol Kakade was busy administering everything as the meeting went on, so we owe him thanks. Amol is an active member of the radiation oncology team over here. He's now consultant, so thanks, Amol. One great surprise I had was that my friend, Dr. Purvish Parikh, has been the MMC observer, and I thank Purvish for being there. I wonder if he was, if he's still around, but Purvish, it was great to just see that you were with us. And of course, to the MMC for giving us the points and making this a worthwhile scientific thing. So let us conclude in time, and thank you very much, everybody. I think we have to thank the institution immensely, our dynamic CEO, Dr. Tarang, the academic unit, the medical administration, and the marketing team, all of them who are constantly supporting us in all our endeavors. So thank you very much, everybody, and good night and Godspeed.
Thank you.
Thank you. Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you, everyone. It was nice.
Yeah.
Thank